So when are we starting?
We're waiting for Sonali to give a cue.
Okay.
Hello, sir. Good afternoon, sir.
Good afternoon. Good afternoon, all.
Good afternoon.
Yes.
Good afternoon.
Just about to start, sir.
Thank you. Good afternoon.
Yes, sir. Good afternoon, sir. Good to have you, sir.
Joining from the hospital. Sorry.
Yes, sir. We are good to go, sir. Good to go. Dr. Hitesh, good to go.
Thank you. Well, a very warm welcome to NALSICON 2020, day 3. This is the second set, day 3 and day 4. Last week, the weekend, it was fantastic. The science we heard, how surgeons actually have a huge role to play in lung cancer even today, contrary to our belief, the role of pulmonologists. And clearly, I think some of those lectures on radiation floored us. The simplicity of our chief guest, Akshay Kumar, was fantastic. I mean, it was unbelievable. And the discussion Mr. Bhushan and Suhail Seth had was something I think I'll remember for a lifetime. But day 3 today and day 4 is going to be a very different feel. It is highly science bound. We will hear some cutting edge discussions and science into practice from all the stalwarts of lung cancer, as I can see, both nationally and internationally. But to begin with, I think it is the case-based discussion which is so critical to us. And I'll hand over to Dr. Charu, who will discuss a case-based discussion on locally advanced lung cancer with the extremely decorated panel with Dr. Raja, Dr. Pramila Pankaj, Dr. Kanika Sood, Puneet Gupta, and Shubham Jain. Over to Charu. Thank you.
Thank you, Nitesh. And welcome, panelists. So Dr. Nitesh has already introduced Dr. Puneet, who's a pulmonologist at Max Institute of Cancer Care. Dr. Pramila, she heads the Department of Nuclear Medicine at Max Institute of Cancer Care, Shalimar Bagh. Dr. Kanika, she's a radiation oncologist and she heads the Department of Radiation Oncology at Dharamshila Narayana Super Speciality Hospital, Delhi. Dr. T. Raja has joined us from Apollo Speciality Cancer Hospital, Chennai. He is an eminent medical oncologist. And then we have our young, energetic surgeon, Dr. Shubham Jain from Max Institute of Cancer Care, Delhi. So I'm going to make you walk through a case straight out of the clinic. So he is a 63-year-old gentleman, Mr. AB, who doesn't have any comorbidities, and he is a chronic smoker, 20 pack years. He presented in January 2020 with complaints of cough with expectoration, intermittent since 2 years, increased since last 2 months, off and on, low-grade fever since 2 years, and then breathlessness on exertion for 2 months. He has a massive weight loss of approximately 11 kgs in 6 months, and there is no hemoptysis or headache. So from the history, I mean, we can see that patient has chronic as well as acute onset of symptoms. And we know these two things, tuberculosis and lung cancer, they overlap a lot. So a chest X-ray was done, which showed an ill-defined opacity in the right mid-zone, and a CT chest showed a ill-defined parenchymal opacity in the right upper lobe and nodular opacity in the right middle lobe. And there were mediastinal lymph nodes, pretracheal, precarinal, and subcarinal lymph nodes. Here you can appreciate that there was ground glassing with interstitial thickening in the right upper lung, upper lobe with interlobar septal thickening. So my first question to my panelists, to Dr. Puneet, is how do you interpret this ground glassing with interstitial thickening, which is confined sharply to one lobe? Dr. Puneet?
Hello.
Dr. Puneet, you have to unmute yourself.
Yeah.
Yes,
I'm
you're
audible now?
now.
Yeah.
Yes.
As we know, this opacity is irregular margin and in upper lobe with certain ground glassing. This presentation can be of two types, in tuberculosis also and CA lung also. So we should further diagnose it with bronchoscopy or EBUS or see the lymph node involvement in the lung window.
Okay.
As we've seen, interstitial thickening is there. It could be due to past any granulomatous illness causing fibrosis, and after that superimpose lung cancer or tuberculosis or secondary infection again.
Okay. So he didn't have any past history of any granulomatous disease. And do you think it can be obstructive pneumonitis or bronchiolitis presenting like this? Because normally miliary or lymphangitic would be, bilaterally and in bilateral lungs. So you would be seeing more of these confined sharply to one lobe kind of interstitial thickening.
Yeah.
Dr. Bromel, any comments from your side?
Am I audible?
Yes.
Yeah, seeing just from the CT images, it looks like it could be the CT gives more of a picture of it could be infective pathology because there are more of a ground glass haziness, and as such there is no mass seen anywhere, and it could be because the CT findings are more look like to be infective rather than mitotic, just seeing on the CT images.
Okay, thank you, Dr. Brahmala. So, Dr. Puneet, how would you like to proceed in this case?
First, we should do the bronchoscopy. If sputum is available, then we can go for sputum examination for malignant cell also and for tuberculosis to rule out. And for bronchoscopy, we can study the lymph node status by EBUS technique and can take the sample of the different lymph node involvement, and simultaneously with bronchoalveolar lavage, we can study the gene expert for tuberculosis or culture sensitive for any infective pathologies, and in addition to this, cytology for malignant cell to see if any cancer pathology is there or not. As we see the histories of chronic smoker, the chronic smoker are both predisposed to cancer also and tuberculosis also.
Great, Dr. Puneet. So that is what our patient underwent. So outside he went a bronchoscopy, which showed that the right upper lobe was completely obstructed with the lesion, and there was infiltration in the right middle lobe on the lateral side, which was 1 centimeter away from the carina, and left bronchial tree was normal. The biopsy was taken and it came out to be a moderately differentiated squamous cell carcinoma. So I would now like Dr. T. Raja to step in and tell us, what is the emerging role of molecular markers in a squamous cell carcinoma of lung? Dr. T. Raja.
Thank you, Dr. Garg. for inviting, and thank Dr. The entire Nalcon team for this invite. I just want to also add to what has been asked to our pulmonologists, but of course, it's now a retrospective knowledge that I now have the bronchoscopy in front of me and then the findings. So the whole thing is kind of an atelectatic lung, post-atelectatic, change. This is often well explained by CA lung as the probability. And again, the disease is located quite close, 1 centimeter away from the carina. And as was seen in the bronchoscopy, there's a bit of an obstruction. So I think that explains the radiological picture. So I'll be very keen to know that, because I want to have the bronchoscopy done. I want to get the EBUS done. I want to look at those lymph nodes. And I really want an FNA of those lymph nodes as much as possible to make sure that our lymph nodes are also well defined. So
We'll give you that.
that's what I want to add here to what has been already told. With regard to your question about the squamous cell carcinoma of the lung, I think the MO is probably medical oncologist, I suppose, and it's not an M0 that you're.
No, not at all.
And so nowadays, we are kind of a little open with both, squamous and non-squamous, and our upfront reflex testing is involving both for squamous and non-squamous. I would send a complete panel in all our patients in the metastatic setting. I'll be looking for all the markers, even in squamous cell. Of course, the percentage of driver mutations are definitely higher in the in the adenocarcinoma, but again, we know that there are expression of these mutations, so on and so forth, and we definitely have treatment decisions to make on these changes. So I'll be asking for almost a similar panel what I asked for adenocarcinomas.
Thank you, Dr. T. Raja. So I think that is a change which we have seen recently, and now we are sending our driver mutations for squamous cell carcinomas, particularly if the patient is a non-smoker, young, or if you have a small histology biopsy sample, or it is a mixed histology. Great, thank you.
PL1 goes automatically for all of us, all of the patients.
Okay, thank you. So this was the PET CT which we got done, and as you can see that there is an FDG avid thickening in right hilar, suprahilar region, and reaching up to the costal pleura anteriorly, encasing the right main bronchus, and then there were discrete and confluent nodular opacities in the right lung upper lobe, and multiple FDG avid lymph nodes. And there were no other FDG avidity seen in the body anywhere else, and ground glassing with interstitial thickening in the right upper lobe, which you had seen on the CT as well. So, I mean, these I've just put to show you how clearly demarcated it is confined to one lobe. So now my question to Dr. Pramila. Dr. Pramila, is there any PET criteria to differentiate these lobes from pathology vis-a-vis a malignant pathology?
So as such, there is no absolute criteria to differentiate benign versus malignant. Although so much has been said about SUV max, which we always report in our reporting, but SUV max is the metabolic activity level of any given lesion, which is dependent on so many things, like how much is the tumor size, what is the histopathology of the lesion. Like in cases of there is so much overlap between infection versus mitotic activity. They are also hypermetabolic to tumor and infection, both are metabolically active. So on the basis of just SUV, we cannot differentiate between benign versus malignant. At the same time, like you can get various false negative ratios in cases of small lesions. If the lesion cellular, even mitotic lesion with low cellular activity, like in cases of mucinous adenocarcinoma, we may get false negative SUV values. But at the same time, we have got very high uptake in cases of tuberculomas or various infections. So there is no absolute criteria. When you are reporting PET findings, you have to see everything in toto. Just reporting SUV or image finding, you may land up in doing so many mistakes. So we have to see everything. We take into everything into patient history in context, scan finding in context, and sometimes the clinical opinion of the physician, which gives us a very much insight, deep insight into the patient. And then we report everything in complete totality. So no absolute criteria.
So that is why now we have residents in the nuclear medicine department also who exclusively takes the history of the patients.
Yes.
And like very brightly, a meta-analysis concluded that the FDG PET can diagnose malignant pulmonary lesions with an estimated sensitivity of 94.2% and specificity of 83.3%.
Yeah, it depends. Like in cases of, if the SUVs of the lesions are very high, then the chances of this being mitotic is high, but this is not an absolute area. So that is why we take a very detailed image of all the patients which we comes to us. So it's not just, we are not reporting only the scan findings. That is why nuclear medicine persons are called physicians. So we are physicians. So we have to take everything into totality.
Coming back to you only, Dr. Pramila, according to you, like in how many cases, percentage of cases, would a PET CT would upstage or downstage a lung cancer patient?
So if you see, in case up to 40% of cases, the change whether they are either upstaged or downstage, depending upon the PET results. Upstage because in cases of because PET is very good in detecting delineating the mediastinal lymph node staging, as well as it sometimes in more than 10% of cases PET gives you unexpected metastasis can be detected, because here we are screening the whole body of the patient. So on the basis of that, it changed the TNM staging up to 40%. And it changed the management of patient in case up to, one study has reported up to 72% of cases, and almost in 1 in 5 patients we can reduce the chances of doing unnecessary surgery or unnecessary intervention, because we find patient have distant metastasis or nodal staging is high. We detect N2 staging in cases of lung. Then in those cases, there is no use of doing any futile surgeries. So it changed management up to 40% of cases of patients.
Very rightly said, Dr. Pramila, 40% upstage, 10% downstage, 10% unexpected meds. So that's a huge figure.
That's a huge figure.
Yeah. So as Dr. T. Raja was saying that he would like to know the status of the lymph nodes. So we know that even if we have a proven primary, these nodes, they cannot be taken at its face value with an increased FDG avidity. We know that EBUS is the preferred modality for assessing the nodes. I would like to ask Dr. Shubham, is there any particular situation where you would sort of prefer mediastinoscopy in addition or over to EBUS?
Hi, Dr. Charu. So, EBUS and mediastinoscopy, I would keep them as complementary to each other rather than supplementary. So, an EBUS definitely has a role prior to mediastinoscopy, but just in case where logistics are not feasible, or that the EBUS has been done, has been reported as negative, but the clinical suspicion still continues to be high, I would definitely prefer to subject the patient to a mediastinoscopy, which is the gold standard for mediastinal staging in those cases.
So, is there any lymph nodal stations which you cannot access by EBUS and you can do by mediastinoscopy, or the amount of tissue which you get in EBUS vis-a-vis mediastinoscopy, is there a difference in that?
So EBUS essentially provides us an FNA tissue only. So if there is a possibility at sometimes in cases where we are not able to get a diagnosis of more than a poorly differentiated carcinoma. So definitely where we need more tissue to do IHCs, there definitely mediastinoscopy is preferred. So the need for more tissues is definitely another indication where we would prefer it over an EBUS. But it's not, as I said, it's not a supplementary modality, it's a complementary modality. So when we have a primary in the lung, as in this case, and there are mediastinal nodes, then definitely mediastinoscopy would help us in establishing the status of nodes, even in case EBUS is negative and the clinical suspicion continues to be high.
Okay, thank you. So mediastin, for logistics reason, we could not do a EBUS, and this patient underwent a mediastinoscopy with lymph node biopsy, and there were enlarged lymph nodes seen in 2R, 4R, and subcarinal region. And biopsy, as you can see, that level 2R showed a metastatic deposit of moderately differentiated squamous cell carcinoma with ECE, and level 4R and subcarinal node shows non-caseating granuloma with no tumor deposits. So I will come back to Dr. Puneet. Dr. Puneet, how do you now sort of manage this case where you have granulomas and you know that you have got a diagnosis of cancer?
Yeah, actually, in this tertiary setup, we are getting some lots of patient referred from periphery, where there is history of tuberculosis treatment and this upper lobe shadows is not going after serial X-rays. They miss the diagnosis of cancer. Then we diagnose them as a lung cancer, which initially was examined by peripheral doctor as a pulmonary tuberculosis. There are two type of cases, either wrongly diagnosed or correctly diagnosed as a tuberculosis case coexisting with the lung cancer. So due to past history of tuberculosis also, if there is any scarring, there increased chance of developing lung cancer if patient is having chronic smoking history. So we start the ATT according to the condition of smear result or this culture result, and simultaneously if patient is having coexisting cancer, lung cancer also, then we start this cancer therapy also according to our oncologist colleague, and we simultaneously treat both.
Okay. So hold of DDs for non-caseating granulomas, which would a few of them will be pertinent to India, not all. And so Mr. AB was started on AKT after investigations, and the final staging, it was staged as T3N2, stage 3B. So I would like to ask Dr. T. Raja, how often do you see tuberculosis and cancer coexisting in your clinical practice?
I mean, to the contrary to the belief, I just want to state whatever I see. Again, that may be different from different hospital experiences. Basically, because different hospital means we're talking about clearly different socio, economic background. So I have to humbly state that at each hospital, at whatever level, the experience may be different. Again, that's only my impression. I don't see tuberculosis coexisting with, in this case, lung cancer that very often as I would like to imagine, even though there are patients of tuberculosis that I can see with any of the malignancies mixed up. So but in my opinion, I would, if I have to hazard a guess, probably only 5% or less than, definitely less than 10% in our setup. That's what I want to add. Maybe the experience is different in a larger general hospital. Now, I just want to go back to, if you permit me, I'll just add a couple of things to whatever surgical oncologist had added. The whole purpose of evaluating the mediastinum is to define the loco-regionality of the disease and what do you want to do. And therefore, if you look at the sensitivity and specificity of each of the investigations, of course, PET-CT, as was rightly mentioned, a certain sensitivity and specificity. Therefore, you want these investigations, invasive investigations, because you want 100% specificity, then you go for all these invasive. If you do a EBUS-US, that can actually supersede a mediastinoscopy in sensitivity and equal mediastinoscopy in specificity. Only if EBUS-US is negative, and then there is a clinical suspicion, we don't know what is there on the PET, then mediastinoscopy is a good investigation. And again, if a tissue was exactly like you pointed out. Here, my point here is that only one node, that is the upper paratracheal 2R, is positive. And the rest of the two lymph nodes were negative. So this is a single station N2. And going back to the anatomy of, if it was originally T2, but if I have to consider two lobe lesion, it is a T4. And it's a T4 and a single station N2 may still be a good candidate for surgical consideration. So I want to be very, very clear on all that.
Sure. So it was basically T3. It was just one lobe and there was some nodule seen in that one lobe.
No,
So,
I thought you showed upper lobe and middle lobe. If
so
I'm
it was
not
just the only part of the, the bronchus was infiltrating.
okay.
Yeah. So as Dr. Puneet also said that, a study conducted by the NCI, they found that patients with pulmonary tuberculosis had increased of lung cancer. And another estimated a twofold elevation in risk of lung cancer in men with tuberculosis. And tuberculosis will increase the risk of lung cancer through substantial prolonged inflammation, host tissue damage, fibrosis, scar formation, and genetic alterations.
So this is from NCI, basically from United States incidents. Do we
Yes.
have the Indian? I'm sure our pulmonologists definitely have a lot of it.
Yes. In fact, the other thing also what they said that, the coexistence of TB and lung cancer, they estimated at 2%, but I'm pretty sure in India, we would have it more. I couldn't really find the data for that.
There are some data from Kolkata, Dr. Kakuli et al. They have done certain retrospective studies. So they also have found around 3 to 4% incidence of tuberculosis with lung cancer. They segregated them as those who had 2 months previous to the diagnosis of cancer, synchronous, and during the course of treatment. So they've quoted around 3 to 4%.
Okay. Thank you, Kanika. So, what Dr. Puneet was discussing, because of the pulmonary tuberculosis and lung cancer coexisting, there can be a delay in making a diagnosis of approximately 11.7 months as it was in this study. So a high index of suspicion of double pathology is warranted in the setting of a predominant or a growing nodule during the treatment for active tuberculosis. So now I would like to come back to Shubham. Shubham, would you like to operate on this patient? If we say it is if it is a single station node which was positive and a T3 lesion, would you like to operate this patient upfront or after NACT?
So with the mediastinum positive, definitely upfront surgery is out of the question. What we could debate here is the disease burden in the mediastinum. So I believe that the node, because it was showing extracapsular extension as well, and it's a T2 lesion causing obstructive changes in the right upper lobe, this can fairly be considered as a disease with a bulky mediastinum disease burden. So we definitely need to start this patient on NACT, and we can then assess the response based on that. If the mediastinum still continues to be positive, then definitely this patient goes for a chemoradiation. If following that we are able to achieve sterility of the mediastinum, we may consider, depending on the fitness of the patient, for a surgery vis-a-vis a radiation. But if we consider the extracapsular extension as a marker of bulky mediastinal disease burden, definitely surgery is out of the question then.
Okay. Thank you, Shubham. So I'll skip this question that in case if you have to operate, once the patient turns negative in 2 or 3 weeks time, then we can, operate that patient. Now coming back to my medical oncologist and radiation oncologist, I would like to ask Dr. Raja first, followed by Dr. Kanika. How would you like to sequence the treatment of this patient of anti-COX treatment, chemotherapy, and radiation? Dr. Raja.
Yeah, I mean, once our surgeon is happy to let us deal with the patient, then comes the standard of care is CTRT, and the only variable in this patient is a possible tuberculosis. Again, it's only a non-caseating granuloma. Again, if I have to just raise some, what if this is something
sorry,
else?
Just one, Charu, sorry,
Yes.
interrupting, just 2 minutes left, so we'll have to close
Okay,
this soon.
okay.
Thank you.
Okay, then I would just start AKT, wait for 1 or 2 weeks and get going. That's what we do.
Okay. So I'm not going to ask Dr. Raja this. So basically the role of durvalumab is there in squamous cell carcinoma also, and we don't need any molecular markers for doing that. I would like to ask Kanika, like which radiotherapy technique would you, advise the patient, and how has the modern techniques changed the outcomes of advanced lung cancer?
This particular case, I would say, is the standard case which I would select for an image guided radiation, because this patient has obstruction, is likely to have opening up of the bronchus during the course of treatment, and the entire anatomical changes need to be followed up because you will have to adapt your radiation portals as per the opening up of the lung. So image guidance, I think, is the preferred treatment here. And with adaptive being considered somewhere between 3rd week to 4th week, as the lung parenchyma opens up, you can redefine your tumor volumes, and PET-based planning, because PET can guide you in terms of your volume delineation. And surely I would prefer to treat it after some clearing of the tubercular changes, because PET, as Madam Pramila said, would not guide us in telling that which is disease and which is tuberculosis. So at least tuberculosis clears up, then your volumes are better defined. So adaptive under an image guidance. It will also reduce the pneumonitis if it is performed aptly.
Yes, so the retrospective studies basically have shown that there is a improvement in survival, but our RTOG 061, which was a prospective trial, showed showed no improvement in survival, but yes, radiation pneumonitis, the cardiac doses, everything was less. So I think
I'll have to stop you there.
yes. Okay, sure.
We have sworn we'll stick to time. I know the discussion was getting more interesting, and I would have loved to hear more.
Thank you.
But thank you.
I would thank you, my esteemed panelists, for joining in, and thank you for a wonderful.
Thank you, Nitesh. Thank you, Char.
Thank you.
Thank you very much.
Thank you, Dr. Charu. Thank you, organizers.
As I said, this was getting very interesting, but we have to go over to the next very interesting session. It's again stage 3 lung cancer and the Pacific trial. And we have no other than a very young, budding, extremely enthusiastic Dr. Sonam Puri, all the way from San Diego, who will be giving us a talk on the Pacific trial. And can I also please humbly invite Dr. Julka, who will be the chair of the session and will give his few comments in the end. Dr. Sonam Puri, could you please take over the mic?
Yeah, hi Nitish. I'm just trying to start my video, but it just says you cannot start your video because the host has stopped it.
We'll just try to do that. Sonali?
Yep, done. Good evening. Nitish, thanks a lot for giving me the opportunity to present in NALCON. So today I'm going to be presenting on a very interesting topic of how immunotherapy made an entry into the treatment of unresectable stage 3 non-small cell lung cancer with the Pacific trial. Here are my disclosures. So today, I'm just briefly going to be talking about immunotherapy in treatment of non-small cell lung cancer with an overview of the Pacific trial and special focus on what are we doing now in clinic once the Pacific trial has been approved for treatment. So we all know that approximately 1/3 of patients with non-small cell lung cancer are diagnosed with stage 3, despite offering them treatment that is theoretically with a curative intent. The 5-year survival is dismal after concurrent chemoradiation for unresectable disease, with a survival of around 13 to 26%. Before the Pacific trial, there had been many interventions, many trials that tried adding additional vaccines or targeted therapy in an unselected population of patients after concurrent chemoradiation that failed to show any survival advantage. That brings me to immunotherapy in lung cancer. We all know that immune checkpoint inhibitors have really changed the landscape of treatment of advanced non-small cell lung cancer, with many FDA approvals due to survival advantage over the last 5 years. The rationale for really combining immune checkpoint inhibitors with radiation in an unresectable stage 3 setting stems from the inherent immunomodulatory property of radiation that and its effect on the tumor microenvironment, which works synergistically with immune checkpoint inhibitor. So we know that radiation can lead to increased antigen release, upregulation of PD-L1 and other immunomodulatory cell molecules, which in turn actually has a capability of converting an immunotherapy refractory tumor to an immunotherapy responsive tumor. Durvalumab is the immunotherapy which is used in patients with stage 3 non-small cell lung cancer. And I just wanted to discuss that a little bit more. It's a selective high affinity IgG1 monoclonal antibody that basically blocks the PDL1 ligand on the tumor cell and really blocks its binding to PD1 on T cells, which leads to stimulation of these cytotoxic T cells to recognize and ultimately kill the tumor. Coming to the PACIFIC trial, so this was really a practice-changing trial for us. It was a phase 3 global placebo-controlled, blinded, randomized control trial that looked at patients with unresectable stage 3 non-small cell lung cancer that did not show any progression of disease after concurrent platinum-based chemotherapy. Patients were enrolled irrespective of PDL1 status, and in fact, knowing the PDL1 status was not required at the time of enrollment. Then the patients were randomized in a 2:1 fashion to receive durvalumab at 10 milligram per kg every 2 weeks for up to 12 months or placebo. The co-primary endpoints of the study were progression-free survival and overall survival. So the results initially were reported in 2017 that showed a pretty significant impact of 12 months of durvalumab on the progression-free survival. After a median follow-up around 14 months, patients who received durvalumab had a median PFS of 16.8 months compared to placebo, which was 5.6 months with a hazard ratio of 0.52. We can see that there was an early separation of curves that remained separated. And based on this really compelling data, FDA approved treatment of durvalumab after concurrent chemoradiation in the United States. It wasn't surprising that actually the improvement in progression-free survival did translate into an improvement in overall survival. And here I'm presenting the 3-year overall survival data, which was presented by my mentor, Dr. Gray, at ASCO in 2020. And here we see that 3-year overall survival with durvalumab was 57% compared to 43% with placebo. The other interesting part about the PACIFIC trial was the key secondary endpoints, which I believe were pretty clinically relevant. So when the authors looked at time to death or distant metastasis in the intention to treat population, durvalumab again had a benefit with an improvement in time to death and distant metastasis to about 28.3 months compared to 16 months in the placebo arm. What was interesting is when the authors looked at the specific incidence of new lesions at the time of relapse, there was in fact a decrease in incidence of brain disease at the time of relapse, which was 11.8% in the placebo arm compared to 6.3% in the durvalumab arm. The PACIFIC trial did have a pretty robust profile of pre-specified subgroup analysis. And here you can see it's a forest plot that showed that there was benefit really seen across the board, except for a few exceptions. I would just like to discuss the 2 subgroups of most clinical importance here. So when the authors looked at patients who had known EGFR mutation, the benefit was really uncertain, but it's important to note here that the EGFR testing is not required in stage 3 lung cancer. It's no surprise that actually very few patients had an EGFR status known in this trial. And that's why it's very difficult to make any strong clinical interpretations from this. But if we learn from the data in the metastatic setting, we know that immunotherapy as a single agent doesn't really work for this population of patients. So it's definitely something that's hypothesis generating. The other thing which was interesting is the efficacy also was dependent on the time of randomization. So this trial, really the start point of this trial was after concurrent chemoradiation. And the authors saw that if they randomized patients to durvalumab, within 14 days of completing concurrent chemoradiation, they seem to do well compared to those patients who were randomized after 14 days. Again, this can be completely confounded by the fact that, in fact, the people who can be enrolled into the durvalumab arm within 14 days were probably the ones who were the healthiest and did not have any side effects from concurrent chemoradiation. a subgroup analysis in PACIFIC trial, which was kind of interesting and also very controversial, was the subgroup analysis of the PDL1 expression. Again, this trial did not mandate PDL1 testing as an accrual criteria. And the pre-specified subgroup analysis was a PDL1 of greater than 25% or less than 25%. However, on request of the regulatory authorities from Europe, the authors conducted a post hoc exploratory analysis in which they looked at PDL1 expression of less than 1% and more than 1%. And to note here that PDL1 was only evaluable in like 63% of patients. So the authors found that there's actually no significant efficacy of durvalumab in the population of patients that was PDL1 negative. Again, this is hypothesis generating. This has definitely impacted the guidelines in Europe, but has not impacted the guidelines for us in United States, where durvalumab is approved irrespective of the PDL1 status. Now coming to the toxicity, it's a very important topic because we are committing somebody to 12 additional months of therapy after they receive probably what I think is the most difficult treatment in non-small cell lung cancer. When we looked at the toxicity data from the PACIFIC trial after a median follow-up of 25.2 months in the second interim analysis, it was noted that grade 3 or 4 adverse events were seen in around 30% of patients in the durvalumab arm, which was pretty comparable to 26.1% in patients with the placebo arm. Discontinuation of trials due to adverse events was seen in 15% of patients in the durvalumab arm, compared to 9.8% in the placebo arm. Coming to the adverse events of like real importance, which is immune-mediated adverse events, as expected, immune-mediated adverse events were more common in patients in the durvalumab arm compared to placebo arm. I think one of the most feared side effects when you are committing somebody to immunotherapy after radiation is pneumonitis. And we did see that, in fact, 1/3 of patients in the durvalumab arm had any grade pneumonitis compared to 24% in the placebo group. In my clinical practice, I think this figure holds true. I do see 1/3 of patients really getting some kind of pneumonitis. However, it's usually grade 1 and 2. It just resolves with like sometimes drug hold and a shot and a taper of steroids. It's important to know that the non-pneumonitis immune-mediated adverse events were actually not that serious. It was mainly just thyroid dysfunction or dermatitis, which are very easily manageable clinically. Now, really coming to the crux of the topic here is like, how does PACIFIC trial translate into me treating a patient in the clinic? I think as anything,
we have few minutes left, please.
Okay. Yep. As anything in oncology, I think it really depends on the risk and benefit ratio. For me, the points that go in favor of the PACIFIC trial was it was a global study that showed an overall survival benefit in a curative intent treatment. It did show a decrease in incidence of CNS relapse with really no detrimental effect on patient-reported outcomes. The things that go against the study was it was a heterogeneous study population, and actually PET-CT, which is a pretty standard staging procedure, was not required as part of accrual. So we don't know if we were treating micrometastatic disease. The subgroup analysis interpretation is definitely challenging. And then we come to the practical challenges related to duration of therapy, access, cost, and risk of toxicity. So what have we done to solve these practical problems at our Cancer Institute at Huntsman? So we have many patient assistance programs that help with financial assistance for patients whose insurance doesn't cover durvalumab. And now in the COVID era, we are transitioning to durvalumab every 4-week dosing, which we took from the Caspian trial, and it does get approved for majority of our patients. But in future, I think we really need to know that do we need the 12 months of treatment, or we can go by with the same survival benefit with this shorter treatment? And do we really need that whole 12 months of consolidation? Can we just get away with neoadjuvant immunotherapy or concurrent immunotherapy? So I think in conclusion, to answer the question, did PACIFIC trial change the practice? I think absolutely it did, because the trial outcome data is pretty compelling with a survival advantage in a population that did not see see an improvement in survival for many years. There are definitely challenges with interpretation of the subgroup analysis and challenges in real-world patients. I think one population that stands out to me is the driver mutation-driven population that historically does not respond well to immunotherapy. With this, I would like to thank the organizers for giving me the opportunity to present.
Thank you. Sonam, that was a very difficult trial, actually put very simply. Thank you very much. Can I ask Dr. Julka to ask just one question before we move on? We are short of time.
Yes, Sonam, excellent presentation. And we have had few patients in the trial, in the Pacific trial, and we have been using 2 weekly dosage, 10 milligram per kg. And we have not had even a single adverse event immune related, excellent responses, and people even after 1 year, they are doing so well that we have asked the company to further give them the subsidized cost. Now the only drawback is the cost of the drug here in India. I don't know about US, but the cost of the drug in India is enormous, and they are giving some patient assistance programs. But cost is the main factor which is deterring us to use in more patients. But we want to use in most of the patients, and I think it is a practice-changing concept. Very good trial.
Yeah, no, I agree. Actually, even though we have insurance coverage for majority of the patients, like even sometimes the co-payment is so much. So like a month of durvalumab can cost like in thousands of dollars, and even if they have a $2,000 co-pay, people really cannot afford it.
Yeah.
Can I make a comment here?
Please, Dr. Khani, please carry on. Yes.
Yeah, thank you. Dr. Sonam, what happens to those patients in this trial who continue to have the smoking? Is there any subgroup analysis or observation that those patients did better in this group, those who continue to have the smoking?
I think what they only noted was a prior history of smoking. I don't think there was any mention of continued smoking. But we know from our understanding of immunotherapy that actually it works better in smokers than never smokers. So, but I don't think there was an subgroup analysis done for ongoing smoking.
Okay, I think I'll have to interrupt. I know this is going to get more interesting, but as I said, we are going to be very sticky for time. Thank you very much, Sonam. I'll hand over the mic to Abhishek Gulia for his most awaited talk on paraneoplastic syndrome. Abhishek.
Thank you, Dr. Nitesh, for the invitation. And right away, I'd like to begin my talk.
Abhishek, you'll ring a bell 1 minute before your end time.
Right. So as far as this paraneoplastic syndromes in lung cancer is concerned, there is no lung cancer conference which is completed without this very important syndromes, which is most commonly associated with a lot of malignancies, but most commonly lung cancers. So beginning with the importance of paraneoplastic syndrome, what actually are paraneoplastic syndromes? So paraneoplastic syndromes are a group of clinical signs or symptoms associated with the malignant diseases that are not directly related to the physical effects, that is invasion, ulceration, or obstruction of the primary or due to the metastatic disease. So in simple terms, these conditions arise due to secretion of functional peptides or hormones from the tumor cells, or due to some immune cross reaction between the normal cells and the tumor cells. Now, as far as the practical and the clinical relevance of paraneoplastic syndrome is concerned, we can understand by this slide that these are the most frequently associated with lung cancer. In as far as 8 to 10% of patients of lung cancer, we can, if we see keenly and observe closely, we can observe paraneoplastic syndromes. There is no relation between the severity of symptoms and the size of primary, and they may manifest before diagnosis and thus contribute in early detection, and obviously it will affect the prognosis of the patient in such a case. They may indicate a recurrence also. They may indicate poor prognosis, more specifically the PNS like hypercalcemia, that is the humoral hypercalcemia of malignancy, or hematological syndromes are associated with very poor prognosis in a few months. and they may indicate better prognosis. More specifically, the neurological PNSs, which are onconeural antibody related, are associated with better prognosis. So the various paraneoplastic manifestations which have been described in literature are endocrine syndromes, neurological syndromes, dermatological syndromes, rheumatologic syndromes, hematological syndromems, glomerulonephropathy, ophthalmologic syndromes, and coagulopathy. The two most common I must specify are the humoral hypercalcemia of malignancy, most commonly seen in squamous cell carcinoma lung, and syndrome of inappropriate secretion of ADH, and more commonly seen in small cell carcinoma of lung. As far as the paraneoplastic endocrine syndromes, there is a definitive criteria for their diagnosis, and all these criteria are not to be met though. So the first criteria is there should be an abnormal endocrine function without physiological feedback regulation. Important thing is without physiological feedback regulation. There should be absence of metastasis in the respective endocrine gland. There should be a deterioration in the endocrine function with increasing tumor burden, and there should be an improvement in the endocrine function with the treatment of tumor. And although this must be the last one, evidence of presence of hormones in the tumor or hormone synthesis by the tumor may not be seen in all the cases. These are the various paraneoplastic endocrine syndromes enumerated. I'll be discussing only the first three in detail because they are the most common ones. That is the humoral hypercalcemia of malignancy, SIADH, and the Cushing syndrome. Coming to the hypercalcemia in lung cancer, as far as 8 to 12% of all lung cancer patients at some stage of the disease will have hypercalcemia. Most commonly observed in squamous cell lung cancer, in whom the incidence can be up to 23%. Hypercalcemia can be caused by either the paraneoplastic syndrome or osteolytic metastasis. And surprisingly, the paraneoplastic syndrome, that is the humoral hypercalcemia of malignancy, is responsible for up to 46 to 76% of hypercalcemia in lung cancers. Now, there are 4 mechanisms described, but the most common mechanism is secretion of parathormone-related peptide from the tumor. And this HHM, or the humoral hypercalcemia of malignancy, is usually associated with increased tumor burden and associated with a very dismal prognosis and a median survival of only 1 to 3 months. To detect hypercalcemia, we should know the clinical features of hypercalcemia, which can be remembered by this line: bones, stones, groans, and psychic moans. So there can be neuropsychiatric manifestations like fatigue, lethargy, mood changes, in severe cases, cognitive dysfunction, and coma. The GI manifestations will be nausea, vomiting, abdomen pains, constipation, and rarely we can have pancreatitis. But if it occurs, it is quite a serious complication. Then renal manifestations include polydipsia, polyuria, nephrolithiasis, and nephrogenic DI. Cardiovascular manifestations include arrhythmia and short QT interval. Now, coming to the humoral hypercalcemia of malignancy, which is basically a diagnosis of exclusion. We should first exclude all other causes like osteolytic metastasis, and then we should diagnose a patient to be having a humoral hypercalcemia of malignancy. For this, obviously, the calcium should be more than 10.5, and it is important to, I would like to stress that it is important to calculate the corrected calcium levels as per the known formula. We should stratify the patients in mild, moderate, and severe, that is 10 to 12, 12 to 14, and more than 14 milligrams per deciliter values. And we should treat aggressively if it is a moderate hypercalcemia, that is more than 12 with symptoms, or if it is a severe hypercalcemia, that is more than 14 milligrams per deciliter. The treatment of hypercalcemia, or rather any paraneoplastic syndrome, is the first thing is treat the tumor. Then we should do, in hypercalcemia, we should manage by hydration with normal saline. Bisphosphonates are commonly used. The onset of action starts at 2 to 3 days. Nadir is reached at 5th to 7th day, and the effect persists for 3 weeks. And then we use denosumab, the rank ligand antibody, and calcitonin, which has a fairly rapid onset of action, but the effect is temporary and partial. Again, I would like to stress HHM confers a very poor prognosis in patients with the expected survival of just 1 to 3 months. Coming to the most famous paraneoplastic syndrome, that is SIADH. So clinical SIADH occurs in around 7 to 6% of small cell lung cancer cases. 70% of all the paraneoplastic SIADH cases are associated with small cell lung cancer. And it is a state in which the patient is euvolemic, that is, he is not dehydrated, and hypoosmolar, and they have hyponatremia. So it is characterized by low serum osmolality and inappropriately high urine osmolality in absence of diuretic treatment, adrenal insufficiency, heart failure, or cirrhosis. Also, they should not be having decreased sodium intake, which is a fairly common thing observed in our cancer patients. And they should not be having, we should rule out sodium wasting due to drug-induced nephrotoxicity and IV infusion of hypotonic fluid. This also indicates a poor survival. The symptoms of SIADH to diagnose, the symptoms will depend upon the development speed of hyponatremia and the degree of hyponatremia, obviously. If it is a slow decline in the serum sodium levels, the symptoms are mostly non-specific and the neurological symptoms are not usually observed. Patient will have vague symptoms of anorexia, nausea, headache, fatigue, and irritability. If the sodium has declined very rapidly or has gone down below 120 milliequivalents per deciliter, then the patients will develop cerebral edema and they'll have features of headache, restlessness, confusion, coma, seizure, and brainstem herniation, which can be, of course, fatal. Now, to diagnose the SIADH, we have set parameters which should be met before we label a patient as having SIADH. The serum sodium should be less than or equal to 135 milliequivalents per liter. There should be low serum osmolarity, less than 275 milliosmoles per kg. The patient should be in a euvolemic state. The urinary osmolarity should be high, more than 300 milliosmoles per kg. The urinary sodium should be more than 20 milliequivalents with normal dietary sodium intake. And of course, we should rule out any thyroid or adrenal or renal failure. Now, the treatment of SIADH is of particular relevance. We should obviously, as other PNSs, we should treat the tumor. The water intake should be preferably restricted less than 1 liter a day. We should always supplement oral salt capsules, extra salt in diet, and we may or may not use diuretics. Now, the use of diuretics is a bit controversial in this one. We can nowadays very commonly we are using tolvaptan, which are ADH-B2 receptor antagonists. We should start off with 15 milligrams per day dose, and then in 21 days we can change the dose to 20 milligrams in a day, and the dose should not exceed more than 60 milligrams per day. And in patients who have hepatic dysfunction, these drugs are to be used with caution. We can also use 3% saline, although this is a very I say it has to be used with a lot of caution. 3% saline in cases where the sodium is less than 120 milliequivalents per deciliter, and the infusion rate should not be more than 1 ml per kg per hour. Obviously, in ICUs or HDUs where we can monitor the infusion rate, because there's a high risk of demyelination, and we should avoid increasing the sodium levels more than 8 to 12 milliequivalents per day. Coming to the ectopic Cushing syndrome, this is also a paraneoplastic endocrine syndrome, most commonly associated with small cell carcinoma lung due to the ectopic secretion of ACTH by the tumor cells. It is seen in around 1.5 to 4.5% cases of small cell carcinoma and indicates a poor prognosis. The important thing is all symptoms of the Cushing syndrome may not be evident in our patients because the prognosis is poor, and because of the aggressive nature of malignancy, these patients may not survive to develop and manifest all these symptoms, which a typical Cushing syndrome patient should have. This is a busy slide, and before labeling a patient is to be having a ectopic Cushing syndrome, we should have at least one of the following which are to be met. At least 2 high readings of 24-hour urinary free cortisol, 2 measurements of late cortisol. There should be a exclusion of iatrogenic hypercortisolism.
Sorry, I have 2 minutes left.
Yes. So as far as treatment is concerned, again, we should treat the tumor. Various drugs have been used like ketoconazole, metyrapone, and they reduce the cortisol synthesis. Now, the second category of PNS are the hematological PNSs. They are often asymptomatic, typically observed in advanced stages, indicate again a poor prognosis, and treatment is to treat the tumor. Specifically, I'd like to stress upon granulocytosis, which is seen in non-small cell carcinoma lung, more commonly with adeno. In these, the tumors have been found to be secreting GCSF, GM-CSF, or interleukin-6. This confers very poor prognosis of around 1.5 months in patients if granulocytosis is there, and usually it is found in the patients along with hypercalcemia. Surprisingly, these are mature granulocytes, and we might think that there might be an increased risk of vaso-occlusion, but since these are mature granulocytes, there is no increased risk of vaso-occlusion. Another interesting sign or paraneoplastic syndrome is Trousseau's sign of malignancy, which we also know as paraneoplastic coagulopathy. It was described initially in 1865 by Dr. Armand Trossiu, who was a legend in the field of medicine. In 1865, he described unexpected and migratory thrombophlebitis in visceral cancers, and unfortunately found it on himself 2 years later, and he died of gastric cancer. So more commonly seen in adenocarcinoma of lung, and the treatment is by low molecular weight heparins. Vitamin K antagonists are not preferred in these cases. Rivaroxaban can be used as an alternative in such cases. Now, the neurological paraneoplastic syndrome, the only paraneoplastic syndromes which confer a better prognosis. The mechanism is onconeural antibodies and antibodies against tumor with cross-reactivity to neural antigens. In 80% of the cases, the neurological symptoms precede the cancer diagnosis. So they help in early diagnosis. And spontaneous regression of malignancy has also been reported in some case reports in which neurological paraneoplastic syndrome have been observed. They can affect CNS, PNS, neuromuscular junctions and muscles. And we have to suspect if there's an unexplained acute, subacute neurological deficits, especially in old age. And these are the various neurological syndromes. Most commonly, they are associated with small cell malignancies.
I'm sorry, but we will have to end there, please. Huh? Please close.
Okay, sir. Okay, yeah. Can I conclude?
Yes, please.
Right. So in conclusion, the timely detection of paraneoplastic syndrome may aid in early diagnosis, early detection of recurrence, and may aid in determining the line of management based on the expected prognosis. The management of PNS may significantly impact the quality of life and also the survival outcomes in our patients. And the elucidation of mechanism of occurrence of these syndromes could lead to possible development of newer therapeutic strategies. So paraneoplastic syndromes are not only theoretical, but hold a very great practical significance as far as lung cancer is concerned. Thank you.
Thank you very much. I'll have a quick 2-line comment from Dr. Somani and Dr. Julka, and then I will move forward.
Thank you, Nitesh, to give this opportunity. I don't think that in the constraint of the time we should expand this talk further, but it was well covered by Dr. Abhishek. I really congratulate him for this and excellent talk by the previous speaker. And we can have more and more questions on that session, but I think enough is covered out of that. And with this, I hand over back to you.
Yes, Dr. Abhishek, you have done a wonderful job, I think, in listing the paraneoplastic syndromes, and they are often with poor prognosis, as we all know, whether it is hematological or neurological or any other paraneoplastic syndrome, which you have very clearly highlighted, and they're all with poor prognosis. And the only thing is how to identify them. You know, coagulopathy, sometimes we think it is not related to a paraneoplastic syndrome. So best is to identify them, identify the paraneoplastic, and then treat the tumor per se. Thank you very much.
Thank you very much, Dr. Julka and Dr. Somani. Now we have a very interesting Roche-supported 2 talks. One is by a very close friend and a fraternity, Ullas Batra, who's going to be speaking about Empower 150. And then one of the most awaited discussions from none other than Dr. Jeffrey Ross. But I'll hand over to Dr. Vineet Talwar, who will be the chair here. And I'll invite Ullas at the same time to start his talk. Thank you, Dr. Talwar, for chairing the session.
Yeah, thank you, Nitesh. And without much ado, let me invite Dr. Ullas Batra, who's a senior consultant in Department of Medical Oncology and a dear friend at Rajiv Gandhi Cancer Institute and Research Center. He will be delving upon the IMpower 150 study, which is atezolizumab plus bevacizumab plus chemotherapy. First line, who, why, and when. Over to you, Ullas, please.
Okay, thank you, Dr. Talwar, and thank you, Nitesh, for the kind invitation. And here I go. Here I go. So I was asked to speak about the IMpower 150 atezolizumab in combination with Bev and chemotherapy. Who, why, and when. And my first thoughts when I saw this topic was, and first of all, Nitesh, you look good. Post-COVID, you have just become a bit more stern, I guess I would say, with the time schedules over here, but you look good. Again, so my first thoughts when I saw this was basically my fond memories of ABCP. You know, Nitesh, I think you will remember, were basically from a debate between Dr. T.P. Sahu and Dr. Kumar Prabhash. One of them actually said ABCP in non-small cell lung cancer, 4 drugs in non-small cell lung cancer stage 4, leukemia treat kar rahe ho kya? I will not name the guy who said this, but I think we all of us know who actually said that. My subsequent reaction was, yaar, ABCP 4 drug kuch to hoga. And then I got this very nice talk which says, you know, kyun dare zindagi mein kya hoga? Kuch na kuch hoga to tajurba hi hoga. I think age has basically, you know, got me into a very philosophical mode right now, which has said this. Now, my first thing was, let me start with saying with atezolizumab in combination with bevacizumab and chemotherapy, who, why, and when. And I will start with why this Colavari-D. You know, why? I mean, why this combination of ABCP is accepted over here? All of you would know. So let's just remember there was a trial which had basically compared pemetrexed cisplatin versus paclitaxel, and the PFS and OS was the same. So this was the trial which was presented in 2015. PFS and OS of pemetrexed cisplatin was the standard regimen, paclitaxel was the standard regimen, and this was the trial which was compared. So what I will just like to add is, so PEM-CIS plus pembrolizumab became the KN-189 regimen. Paclitaxel plus atezolizumab became the IM-power regimen. So there is where the answer to why this Colavari-D is. In US, you know, paclitaxel is the sign of care. You add atezo, it becomes the IM-power regimens, and if you give the PEM-CIS plus pembro, it becomes the KN-198. So that was the answer to why this Colavari-D. The rationale for atezolizumab and bevacizumab plus chemotherapy is this. It's a very scary slide. But basically what it does is it acts as a synergistic combination. Because of bevacizumab, it allows them to recognize the T cells. Bevacizumab helps to recruit the T cells. Bevacizumab helps to reprogram the T cells. Atezolizumab's ability to restore anti-cancer immunity is increased. It restores. I don't know. I mean, I think bevacizumab is like Nitesh Rohtagi, you know, who can do everything and everything. Bad joke to say right now in terms of COVID era, but bevacizumab is one which is supposed to add to atezolizumab. And this basically shows the combination that maybe the postulation was that atezo plus bev will have a synergistic combination, which will say that 1 + 1 is basically more than 2. And that is what we are looking at. So let's look at the IM-power study design. Arm C is the control where you have paclitaxel. Arm A is like a Keynote 189 design, which had 4 to 6 cycles. Arm B is the ABCP regimen, which is the standard, which is the synergistic regimen. So this is what we are basically looking at over here, and this is what the WHO basically comes and says over here. So this is what the regimen was, and ITT over here. Basically, the objective was the IT assessed PFS in the wild type, and you know. The key secondary objective were the PFS and OS in the wild type population and stuff like that. Now, very importantly, where these trials are different is because you had certain bit of 13% people who were EGFR and ALK mutant in both the populations, and that was very, very, very important because none of the regimens had taken this. Now, this was the PFS analysis. Now, here I'll be presenting only between Arm B and Arm C, that is ABCP versus BCP. Forget about the ACP arm because ACP, like in CBI serial, ACP Pradyuman Sinha is useless. I mean, I should not be saying this in a Roche symposium, but for the purpose of this talk, concentrate on the Arm B versus Arm C. Arm C is the standard. Arm B is the comparator. Arm A is just to make the Arm B look good. That's it. So this was the initial results in the ITT WT population, where we can see a PFS of 8.3 versus 6.8. But look at the landmark PFS at 87 at 18 months. You had 27% people who had a PFS free versus only 8%. So this had a 3 times more increase in the PFS. Again, look at the OS. Your OS was better, 19.2 versus 14.7 with the HR of 0.78. typically in this population, we get an HiV of around 0.7 or 0.6, depending on the other regimens that we use. But this was basically a positive trial. So again, if you see 24 months PF OS advantage, 43 versus 34, the drug combination definitely acts very, very well. Now, look at the forest plot curve over here. All subgroups, and as we all know, if your PDL1 is higher, this will have more advantage. The lower the PDL1, that is the tumor cells and the immune cells, it grows, the advantage to a chemo plus immuno combination decreases. Look at the liver mets, look at the EGFR wild type. I will talk to you about that in detail later on. But the point is, all the subgroups, OS was better in the ABCP arm as compared to the BCP arm. This is just a Kaplan-Meier curve to show HR of 0.70, 0.80, 0.82 in high PDL1, PDL1 low. And again, mind it, this is not your typical 22C3. It is both the tumor cells and the immune cells which were seen. And the PDL1 scoring was the SP142, which was used over here. So very importantly, when you use all the chemo regimens, you should, immunotherapy regimens, you should know what platform was it used, so that you can ask your pathologist about what exactly platforms of IHC they are using. So this was the duration of response. And if you look at this, 70% response rate in a PDL1 high, that is TC3 or IC3, was seen in the atezo plus bev plus chemotherapy arm. Now that is something which is very, very good. And again, as the PDL1 grows to slightly less, it decreases from 69 to 58 to 51. But the point is that this drug definitely acts. In the intention to treat population, the response rate was around 56%. And again, the safety analysis data. So if it's a 4 drug, and as one of them rightly said, the drug was slightly toxic, which we can see the serious AEs were observed in 34% patient. But what I would want you to see over here is the safety profiles of ABCP, ACP were similar to A, B, and CP individually. There was no new safety signals were observed with the combination. So whatever side effect you have with atezo or bev or paclitaxel, similar was there. There was no increased risk in complication which was observed with this arm basically. So again, that is what. So this is again to say, this I said was the OS in the ITT wild arm, that is the ACP versus the BCP. I told you ACP arm, not very happy. Your confidence interval had crossed unity 1.08, p-value was not significant. But again, to show that OS in the ITT arm, there was a 5-month difference, 19.8 versus 14.9 with an HR of 0.76. So this is in a ITT wild type population. So this was the summary of the trial, which was presented in ASCO 2018. And they said, I mean, atezo, bev, paclitaxel should be a combination in all the patients of first-line immunotherapy wild type. So this was there, but I know, the moment I put ABCP, there will be a lot of things about single agent atezo, single agent pembro plus chemo. That is not what we are interested in right now. What we are interested right now is, and there's still more to come, as we all know that there is still more. Otherwise, Roche would not waste a 30-minute symposium on an ABCP regimen over here. So let's take it to the next level. Now let's dissect the data. What we mean right now is that PDL1, everybody with a PDL1 more than 50%, whether the patient has got a single bony met, or the patient has got multiple bony mets, or the patient has got multiple liver mets, or the patient has got a multiple lung mets, is the same. Unfortunately, this is not the same thing. What we need to find out is a stage 4 disease is also different, and it needs to be treated differently in all the combinations. So what are the other factors? According to IM Power group, the other two very specific group are liver metastasis and the EGFR mutant TKIs. Let's look at the liver metastasis here. Now, what we all know is that the patients with liver mets, they don't do very, very well. Now, I mean, for everybody who has almost fallen asleep, just wake up for the next 10 minutes. Nitesh also can wake up for the next 10 minutes, and maybe he can then probably go back to sleep after that. So what we know is patients who have liver mets, the PD-1, PD-L1 inhibitors don't do very well. It's a bad disease. And this was, I don't say, this was said in an article in Cancer Immunology Research by May 2017, that people with no liver mets do far better than people with liver mets. Now, this is also a nivolumab subgroup trials, the Checkmate 1757. If you look at the graph on your left, you can find out in the overall study population, it was 11.1 versus 8.1. But if you look at patients with liver mets, the median OS was 6.8 versus 5.9. So nivolumab better, but in patients with liver mets, we need probably something more than only a single agent immunotherapy. The similar thing goes for Keynote 189. If you look at patients with liver mets, you are 12.6 versus 6.6. Yes, it is better, but in patients who do not have liver mets, that's a very favorable biology of disease. You have a median OS of 23.7 versus 13.2 months. So definitely liver mets should be a stratification factor in deciding what immunotherapy regimen to be given, whether we give a single agent, whether we give a single agent with chemotherapy, whether we give a 4-drug therapy. Liver mets should definitely be allowed. Now just look at this trial. If the patient had liver mets, you have 13.3 versus 9.4 months. So please remember the comparator arm also did much well. Remember the Keynote 189, it was 12.3 versus 6. But in patients of liver mets, the BCP arm probably is also a stronger arm, but ABCP scores much more higher with the HR level of 0.52, which is very, very significant. Now look at patients who do not have liver mets. I mean, on one first cursory look, it actually looks like, with the HR of 0.82, that maybe ABCP doesn't work. But no, just look at the median survival in BCP. So what we need to remember is that the Paclitaxel also is a very strong chemo regimen. And if you have liver mets, ABCP is better. If you do not have liver mets, ABCP is still better, although the magnitude of benefit is slightly lesser. Now, look at the ACP arm, it doesn't make a difference. So definitely, it is not about the atezolizumab. It is probably about the combination of atezolizumab plus bevacizumab, which is causing the drug to act better in patients with liver metastasis. So again, patients with liver metastasis have a poor prognosis. Patients with liver metastasis, both the nivolumab and the pembrolizumab trials have not done that better, but definitely in patients with IM power 150, ABCP regimen, the quadruplet regimen, the regimen which a certain very dear friend of mine said, leukemia treat kar rahe ho, probably we need to have a more aggressive regimen for treating patients with liver mets. Now, this is again a very nice forest plot which I showed you earlier. Somebody with liver mets and the patient is a EGFR wild type, your HR ratio is 0.54, which is definitely very, very nice. So we spoke about the ITT population. We spoke about the liver mets population. Now let's look at something where typically immunotherapy has not been shown to have a role. That is patients with oncogene-driven addicted lung cancer who have failed one line of EGFR TKIs. Now, again, this data was presented at ELCC 2019 by Martin Rick, and again at ASCO 2020 by Martin Rick. So again, I'll take you back to the earlier graph. We spoke about IM power 150. 87% of the patients had a wild type of EGFR, but 13% of patients had EGFR ALK mutated, and we are going to see the data of those people right now. So the PFS data, if you look at patients now, the graph on the left is going to be arm A, that is ACP versus BCP, and the graphs on the right is going to be graph that is arm B versus arm C. So once you have a look at, and this is your right and my right on the screen. So PFS and EGFR mutant people, if you have an arm A, arm C, there is no difference. If you look at this 6.9 versus 6.9 months. So probably if you give only atezo plus paclitaxel, it does not make a difference. But if you give ABCP regimen, you have a difference of 10.2 versus 6.9 months, and 10.2 months was the OS, was the PFS which was achieved in the AURA3 trial with osimertinib. Osimertinib became the standard of care after that AURA3 trial, and definitely ABCP should be considered in patients who do not have a T790M mutation and are candidates for further chemotherapy, because the median PFS was 10.2 versus 6.9. Now let's look at the PFS data. Again, is arm A versus arm C? Absolutely unity. Doesn't make a difference. It doesn't change here or there. It is of no use. But if you look at people with arm B and arm C, in all the patients of EGFR mutation, you have a HR of 0.61. In patients with a sensitizing EGFR mutation and who have received prior TKI therapy, your ABCP benefit actually, and the HR ratio is 0.41 and 0.42. Now 0.3 is the HR if you see in the ADAURA trial, and the whole world is going gaga over here. We definitely need to have this ABCP at the back of our mind once we are taking care of a patient who is post his TKI therapy. Now let's look at the overall survival analysis. Again, arm A versus arm C, no difference whatsoever. But if you look at OS in patients with EGFR mutant after they have failed one line of therapy and they are T790 negative, this was the 2019 presentation in which the median was not achieved versus 18.7 months. Now, this is the graph. I will show you. This is the forest plot, which again says that patient in sensitizing EGFR mutation, you have 0.31 of HR, and in patients who have received a prior TKI therapy, the HR is 0.39. And this was the data which was presented at AACR 2020. Just look at the OS. The median OS over here was 29.4 months. Add a certain 10 months, 14 months, 18 months of the earlier TKI, depending on if you use gefitinib or you use dacomatinib or you use osimertinib, and your survival is going to be a mind-boggling somewhere in the range of 40s and 50s. And this was the data which was presented just 3 months back. Again, arm A did not do very well. So HR of 0.60, updated analysis, the minimum follow-up was 32.4 months. And this is again in patients who do not have a T790M. So if you do not have a T790M, at this thing, you give first line TKIs probably 10 months, you give second generation 14 months, and then you add a median 29.4. Survival is going to be fantastic. This was the safety profile. Again, what they said was no new safety signals basically were observed. Median number of cycles which were received was 14 and 12. The grade 5 side effects were none. Grade 3, 4 side effects were there. But the number of populations, as we know, is very, very small over here. But definitely ABCP is a option which is worth considering in people, in EGFR mutant people who have progressed on EGFR TKIs. So I will like to conclude by saying, just don't throw the regimen out of the box just because it's a 4-drug regimen and just because we are not treating chemotherapy. I would like to say there's a time and place for everything, and definitely ABCP also has a place in a lung cancer treatment, and a very special place. This is Nitesh, and the other one I can't recognize over here. This is atezolizumab right now. This is bevacizumab actually, and in patients who have got liver metastasis, and in patients of EGFR mutant who have progressed on first-line TKI, who do not have a T790M, ABCP regimen definitely has a place to go, and hopefully we'll have further follow-up and trials to come. With this, thank you, and I hand it back to the organizers. Thank you.
Thank you very much, Ullas. That was very comprehensive. And I think the fact that you put it exactly where this fits in, because we know everything doesn't fit in everywhere, is fantastic. Vineet, do you have a couple of comments? Otherwise, I'll come to a few questions that are.
Yeah, please continue, Nitesh.
No, please ask some questions if you have any.
To last, no, it's okay.
So
we will discuss these questions in
another forum.
In some other forum. Some other question in some other forum.
I think the question that is commonly coming through is how when you have all the regime sitting in front of you, and let's say this is liver metastasis, you're not talking about the EGFR mutated population. How do you choose A from B? Maybe more from side of toxicity rather than side of efficacy.
So I would say, Nitesh, if we have a fit patient, a young patient, and the liver is studded with disease, I need a response. And if you looked at, and with a high PDL 150, I would not consider a single agent immunotherapy. I would have no qualms because the response rate is 71%. I would have no qualms in maybe, trying the ABCP regimen. although there is no formal comparison between Keynote 189 and ABCP, a young fit individual who is willing to take to maybe tolerate a bit of toxicity, ABCP might just be a good regimen. But in my mind, the real value of this combination is in people who progress on EGFR TKIs. So you can debate about this, but since it's not been tested, so in patients who have got multiple liver mets, I would want to give a combination chemoimmunotherapy. Young fit, ABCP is not a bad regimen at all. Would want to use it.
What about effusions and ascites?
So, I mean, we use bevacizumab in CA, ovary, left, right, and center, and people with ascites and you have said in patients with CA press, it works wonder. So why not?
So, is it one of the reasons that you would choose? And then I'll ask Dr. Julka. I think he has a question to ask too.
Yes, Ullas.
So,
yes, if you have PBCP, Pembro with that, is there a difference?
Sir, so in the Keynote 189, liver mets was not a stratification factor. So it's difficult to compare apples to oranges. What I can say is one of the two regimens, either Keynote 189 or ABCP. That's what I would use. I would not use a single agent immunotherapy. If it's a fitter individuals, I would like to go with 4-drug regimen, get the drug, get the disease good response, and then go ahead with that. Again, sir, we need to remember that, which assay have we done a PDL1 from? So have we done it from the SP142? We need to look at the tumor cells, immune cells. So what assay was there in the laboratory? What else was there? A lot of factors will come into play on this.
I don't think we have any other questions at the moment. Vineet, do you want to make some closing remarks on this, please? And then we'll move on to the next keynote lecture.
Yeah, so Ullas has very nicely alluded to the fact that which is the niche patients which can be given this combination of 4 drugs. Although earlier on we were using a combination of chemotherapy with one target or immunotherapy. 4 drugs, young fit individual, probably that would be the best choice in this case. Otherwise, there are other 2-3 options in which we can exercise. So I think we'll proceed to the next talk.
Thank you. Thank you very much. Yes, I think without further ado, thank you very much, Ullas. That really was very comprehensive. I'll hand over to Dr. Jeff Ross, and I'll ask Vineet to introduce him. But he's really one of the most wonderful speakers that I've ever heard. And I think he understands more about molecular biology and NGS than most others in the world. Vineet, could you kindly introduce him, please?
Yeah, it is my proud privilege to introduce Dr. Jeffrey Ross, who needs no introduction, and he's the medical director of the Foundation Medicine. Everybody knows about Foundation Medicine. And without much ado, Dr. Ross, please.
Thank you so much. I'm going to share my screen to get my presentation loaded. Can everyone see my presentation now?
Yes, yes, we can.
Good. I'll put it into the screen mode. Hopefully that will work fine as well. Always a challenge when we go to screen mode, but how is screen mode still good?
No, it is still the other way.
I wonder why screen mode would go away. I'll go back out of screen mode and just keep in non-screen mode. I don't know why this happens with Zoom every now and then. Back okay now?
You can try it once more. Or Nitesh, probably the tech people can help him. Any backups?
No, I think it is at his end. Dr. Ross, you could try one more time. Otherwise, just move your slide. I think we'll be able to see that.
Let's see. Are you seeing the slides?
No, we're seeing the previous screen.
Can you use the slideshow which is there on the top, the topmost bar, left upper hand corner? It says File, Home, Insert, Design. Go up.
Let's see. I gotta get out of the screen mode here.
Okay.
I'm out of screen mode. Sure.
No,
don't
I think
wanna
we're
do-
still seeing the previous one. Could you come out or stop sharing your screen and share again, please? And then we'll carry on.
Okay, let's see how I do that. So sorry for the end slideshow. Okay, now
Yeah,
I'll share.
this is moving. This is moving. I think if we can use that, then it's quite clear actually.
Good now?
Yes.
Okay, wonderful. Thank you so much for inviting me to speak at the wonderful conference. And as I mentioned in the chat room, I so deeply wish I could have had the opportunity to give this presentation live and meet so many colleagues in the fields of molecular diagnostics, targeted therapy, and especially non-small cell lung cancer. But I'm going to give a presentation now for approximately 25 minutes on the liquid biopsy and the clinical utility of comprehensive genomic profiling with a focus on non-small cell lung cancer. The circulome, a new term that's evolving, talks about the fact that biomarkers can be detected in liquid samples, whether they're circulating tumor RNA, circulating tumor DNA, circulating tumor protein, whether there are extracellular vesicles in circulation, whether whole tumor cells are in circulation, or even tumor impacted platelets in circulation. So there's a great deal of new information emerging from the liquid biopsy. But what is a liquid biopsy? A liquid biopsy is a sample of human liquid which will undergo molecular testing to assist in the management of patients with malignant diseases. And by far and away, the most common source of a liquid biopsy is plasma, is a blood sample. But we occasionally will use spinal fluid, especially for primary brain tumors. And on occasion, we'll use urine for genitourinary cancers. And we do not include bone marrow as a liquid biopsy. We consider it a tissue biopsy. And obviously, it has been used for molecular diagnostics for multiple decades. Now, when we look at the types of samples that are in plasma that create liquid biopsies, we do include the CTC, whole circulating intact tumor cells, of which I'm not going to speak this morning or this evening for everyone in the audience. And we do talk about circulating free DNA, cell-free DNA or cfDNA, which includes bacterial, white blood cell, benign cell, and malignant cell DNA all together. On occasion, though, we refer to ctDNA, and that is only the tumor cell DNA, circulating tumor cell DNA. And this DNA leaks from tumor cells undergoing necrosis or apoptosis, or even possibly from circulating tumor cells that die while in circulation and liberate their DNA. It must be evaluated against the DNA associated with the term clonal hematopoiesis of indeterminate potential, or CHIP, a confounding molecular signature particularly identified in elderly patients. So what patients may benefit from liquid biopsies? Patients who've had disease progression or relapse on targeted therapies, patients who are believed to harbor resistance mutations like the T790M in the earlier days of targeted anti-EGFR therapy, who need new therapy options and entry into clinical trials, for patients in whom a tissue sample is insufficient or has been used by multiple additional testing in the pathology department, such as immunohistochemistry, and there isn't sufficient left in the block to do molecular testing. Also highly necrotic tumors, which won't give a DNA signature. I'll also add patients with bone-only metastatic disease in which the bone sample needs heavy decalcification, which will damage the DNA and prevent it from being sequenced. They may benefit better from a liquid biopsy. For patients whose biopsies have very low tumor content on our mostly benign tissue. For patients who getting a biopsy is either dangerous or impractical. And finally, for patients in which there are multiple resource issues, why a liquid biopsy would be much better. And the shorter turnaround time of doing a liquid biopsy sequencing can also be a benefit. So circulating tumor DNA can provide relevant information at various stages along the patient journey. It can occur in subclinical disease, and I'm sure everyone's been reading about excitement about early detection by circulating tumor DNA for cancer and downstaging cancer by getting liquid biopsy diagnoses far earlier than any imaging or routine tissue testing could provide. But for today, liquid biopsies are mostly being done for assessment of prognosis, for monitoring, and particularly for the selection of therapy, for trying to find a therapy match for the patient that could lead to either a targeted therapy option or an immunotherapy option. So let's talk about this application of liquid biopsy into the non-small cell lung cancer patient care. Firstly, we have what's a very, I think now, popular rainbow pie chart showing how non-small cell lung cancer has changed over the years. I like to tell people when I trained in pathology in the early 1970s, I was told by oncologists that the only thing I needed to tell them was, is it small cell or not small cell? Other than that, it's not important. But boy, have things changed. Look at this chart. There are so many sub-targets and sub-classifications of lung cancer now that non-small cell lung cancer is arguably among the most potentially targetable form of human malignancy. And I've listed on the table many of the targets and drugs that are approved for these targets that you're well familiar with, whether these are alterations in ROS1, ALK, EGFR, RET, NTRK, BRAF, ERBB2, and others. And of course, down at the bottom, the exciting new information about KRAS that we've been waiting for so long, with a high prevalence in non-small cell lung cancer, at least possibly for the KRAS G12C mutation, we now are seeing targeted therapies that are effective. So the liquid biopsy is capable of detecting these alterations in a similar way that tissue samples are, but based on only a phlebotomy sample, not a biopsy, processing into tissue, a pathologist diagnosis, and then referral of the block for extraction of DNA. And when we look at the comparison of liquid-based detection of these important lung targeted therapy opportunities, we see that the liquid biopsy can well match the tissue in many cases. Now, I must say before we go too far ahead that not every lung cancer patient is going to have a sufficient amount of tumor cell DNA, ctDNA, to allow for accurate sequencing and detection of these alterations. Not only that, some alterations are easier to detect than others. And for example, what you know very well, in the EGFR world, it's dominated by either the L858R base substitution or the exon 19 deletion. Well, the ability to detect the exon 19 deletion, whether it's tissue or blood, is much more difficult than detecting the L858R base substitution. The base substitution is easy to find. Deletions are very challenging to find. And if a liquid biopsy has insufficient or low levels of DNA extracted, that can make the detection of the exon 19 deletion very difficult. But when a sensitive hybrid capture-based method of detecting this deletion with an algorithm designed to pick it up even when it's present in minute amounts of the DNA that's been extracted, this has a very high comparison with that seen in tissue, as you see at the top of the chart there, 8.9% in the liquid biopsies and 8.2% in the tissues. And down the list, it can detect the ALK and ROS1 rearrangements, BRAF, V600 base substitutions, even the new target, the MET exon 14 skipping or splice site mutation is detectable with liquid biopsies, as are rearrangements in RET, as well as mutations, both activating and copy number increases in the ERBB2, the HER2. So let's talk a little bit about the newest FDA-approved liquid biopsy in the United States, FoundationOne Liquid CDX. And the CDX is added because the approval for this new assay is not just for the test itself, but the test as a companion diagnostic approved for the prescription of various targeted therapies for patients with a variety of cancers, of course, including non-small cell lung cancer. And the EGFR identification of L858R and exon 19 deletion are FDA approved now. But of course, as I showed before, many other lung cancer relevant mutations are also detected by this sample. This is a major advance over the previous FoundationOne liquid test. The number of genes in the base set is now almost identical to that as the FoundationOne tissue test, FoundationOne CDX, with 324 genes. And it also includes introns of DNA gene rearrangements that can be detected readily by the assay. What's also new in the FoundationOne liquid CDX is the addition of approvals for detection of blood tumor mutational burden and blood tumor fraction, and of course, MSI instability high status. And the reports for this result on this test will include all of those, MSI, TMB, and then whatever additional alterations were detected. So it's an enhancement compared with the previous F1 liquid, more genes, it's incredibly more sensitive, it's capable of detecting these alterations in lower amounts of extracted DNA, and it's been highly validated in multiple comparison studies, both with other liquid biopsy databases, as well as tissue DNA sequence databases. And the actual test itself, FoundationOne Liquid CDX, just earlier this week was published in the PLOS ONE, the validation study. So it is a peer-reviewed, validated, and FDA-approved assay. The liquid CDX and the tissue FoundationOne CDX are complementary. They're similar, but not exact in the number in the genes in their 324 gene total. They both detect the TMB, MSI, but the tissue currently provides an additional feature called the loss of heterozygosity, an important test that's particularly used in ovarian cancer and breast, prostate, and pancreatic cancer for determining the potential of use of drugs such as the PARP inhibitors for homologous recombination defect associated cancers, like these endocrine tumors, breast, ovary, and prostate, as well as pancreatic. But it's a blood-based test, and the patient is sent for phlebotomy to obtain the sample, not to interventional radiology for a tissue biopsy. They build on the strength of each. Now, the gold standard remains tissue. It's what we've been using now for well more than 15 years in the lung cancer area to decide on EGFR status and then the many other targets that emerged over the years. But the blood-based test has some strengths. It's less invasive, as is obvious, with less morbidity. It's a simpler, and the results do come back faster because they don't have the same times for DNA extraction. They don't have the pathology review time that the tissue requires. They don't have to be enriched with benign tissue discarded in order to increase the tumor cell proportions. The sample is ready for extraction when it arrives. It also has an unbiased approach. It pools all of the alterations. It doesn't hierarchically impact them by their ability to be extracted out of paraffin. And it can be done multiple times on the same patient with relative ease, but it's limited. Not all patients will have sufficient circulating tumor DNA to be able to be sequenced and give a result that will guide the oncologist's therapy plan. For non-small cell lung cancer, stage 4, the positive test results are very high. It can be as high as 80 to 85% in most studies. This is unfortunately a tumor type that does present often with widespread disease, and the DNA appears to readily leak into the peripheral blood. There are some tumor types in which getting high quantities of DNA by liquid biopsy is not very easy, and the usual sample size often fails. Maybe even less than 50% of the time do you get an informative sample. but this is not true for non-small cell lung cancer. We get an informative sample from liquid biopsy 80 to 85% of the time when this procedure is performed. But when we do get a negative result, which can be insufficient DNA extracted to sequence at all, or we attempt to sequence and find no alterations, we know then that a tissue sample needs to be obtained if that can be done safely and readily in order to find out what's driving the patient's progressive cancer. Let's talk about some clinical utility. There are numerous key indicators for when we want to use the liquid biopsy. And of course, we're searching for the approved first-line targets such as EGFR, now the KRAS G12C perhaps, certainly ALK, BRAF, ROS1, NTRK, RET, and probably MET exon 14 splice site mutations. Whether FGFR3 will also enter the lung cancer is also exciting, but these are the main ones that we are looking for. We also may find other alterations that are entry criteria for mechanism-based non-small cell lung cancer clinical trials. So the test may be in the trial itself or screen patients for further testing to enter the trial. Immunotherapy biomarkers are a major part of the new FoundationOne liquid CDX test. When we compare the different current biomarkers, which include, of course, the PD-L1 expression by immunohistochemistry, which is widely done in lung cancer to allow patients to potentially receive frontline immunotherapy when their tissues are assessed. We also can detect the gene, PD-L1 gene, also known as CD274. We look for its amplification in our non-small cell lung cancer sequencing samples, whether these are in tissue or in liquid. In some investigators' experience, PD-L1 or CD274 amplification is the most significant predictor of benefit of immunotherapy and outperforms any other test, including PD-L1 expression or tumor mutational burden or microsite satellite instability. This is something we provide, but it's very rarely seen. 1%, 2%, sometimes studies 3%, I've even seen 4% in non-small cell lung cancer will have PD-L1 gene amplification. MSI-high is, of course, a recognized pan-genomic biomarker for immunotherapy, and any lung cancer with an MSI-high status will be considered eligible for immunotherapy, regardless of what the TMB shows or the PD-L1 staining. Now, when MSI-high is present, the TMB, the tumor mutational burden, is virtually always going to be elevated, and certainly going to be elevated above the 10 mutations per megabase of sequenced DNA. And that is the newest pan-cancer approval in the US FDA, making all patients with solid tumors that have 10 or more mutations per megabase eligible for at least for now, the pembrolizumab-based immunotherapy treatment, beta-based, of course, off of the MSI-high database that earlier received a pangenomic approval. So if we move on now to TMB for lung cancer, it's been exciting but somewhat challenging. Early data for single drug immunotherapy was universally accepted. Patients with various cutoffs, 20 was extremely predictive, even 15 was predictive when monotherapy with immunotherapy was given. More recently, there's been some pullback about how TMB integrates with other biomarkers when the immunotherapy drug is going to be combined with another therapy, usually chemotherapy. And more data is needed to know how to use TMB when combination therapy is being planned. That said, both the tissue and now the liquid-based testing provides the TMB, and it is very predictive for single agent and somewhat less predictive for multi-agent immunotherapy protocols. I'm going to show you some data from that fairly quickly to keep on my time. Here's the earliest studies, which were with the Roche drug atezolizumab. In the OAK validation study, you see the Kaplan-Meier curves showing how blood, or BTMB, was predictive of atezolizumab benefit when compared to docetaxel chemotherapy. And this data was published about 3 years ago almost now, and was the first glimpse that blood-based testing of TMB could predict benefit in lung cancer when immunotherapy was being used. This work continued, a second study now using durvalumab, not atezolizumab, in the MYSTIC trial, also showed the ability of blood-based TMB determination to predict the outcome of immunotherapy administration, especially when the immunotherapy was being given as a single agent. More recently, additional trials have been done when combination was used. Here's pembrolizumab with or without chemotherapy being added. And again, the TMB from blood did predict the benefit, and this did hold up whether it was given as single agent or with chemotherapy. So further evidence that blood TMB is a useful biomarker when planning immunotherapy and when to use immunotherapy in advanced non-small cell lung cancer. What about targeted therapy and blood-based testing? As I mentioned, the original approval now of F1 liquid CDX does include EGFR testing. And it also includes, will include ALK testing, and the others will come on board over time as trial data validates that the liquid, like the tissue, predicts a clinical outcome. Here's some of the EGFR drugs that you're all familiar with, and of course the now becoming predominant osimertinib listed down at the bottom. And the liquid biopsy, of course, will diagnose both the primary EGFR alteration, most often the exon 19 deletion or the L858R base substitution, and the acquired T790M. We've also seen the liquid biopsy on a very rare occasion diagnose the T790M as a germline mutation in an unfortunate patient who has non-small cell lung cancer and did not respond to osimertinib at the start, meaning that the T790M in this patient was not an acquired mutation, but was a pre-existing resistance mutation, which would have predicted that the patient could not benefit from the osimertinib therapy alone. If we look at some others, ALK and ROS1 fusions, these are readily detected, and the drugs are listed there, of which I'm sure you're all familiar with. It's a large number, but one thing that the analysis of the data from the liquid biopsy offers is the ability to study the different fusions that occur in ALK or ROS1 and predict which anti-ALK or anti-ROS1 tyrosine kinase inhibitor has the best potential to be effective in this patient. There are many different ALK and ROS1 fusion partners, and they activate the kinase domain of the driver tyrosine kinase receptor in different ways. And the report will often list some of the drugs as effective and others as resistant at the start. And this is based on a large amount of bioinformatic work and the curation team at the Foundation Medicine looking at the exact fusion, something you couldn't get from, for example, a fish-based assay of the tissue, the actual, how do we call it, the preference list of which tyrosine kinase inhibitors are most likely to be effective and which are most likely to be resistant. When we look at the liquid biopsy as a sole testing modality in newly diagnosed non-small cell lung cancer, we can look at ALK-based data here and show that the overall response rate when the IMvigor liquid biopsy alone was used to detect the ALK fusion versus when tissue was used to detect the ALK fusion, and we see the patient response rate being virtually identical. So we are very confident, of course, that not only does the liquid biopsy identify ALK fusions in patients with non-small cell lung cancer, when anti-ALK drugs are given to those patients, they show the same benefit as if the patient had had their original ALK fusion diagnosed from a tissue sample and not from a blood sample. The MET exon 14 skipping mutations are one of the newest targets in non-small cell lung cancer to receive regulatory approval. These are found both in adenocarcinoma and squamous cell carcinoma. Although they are rare, it's very important to detect them because their sensitivity to kinase inhibitors is now well documented. And on this slide, we show the actual genomic diagram of what a skipping mutation at exon 14 in MET is. These tumors often also have MET amplification. MET immunohistochemistry, we have never been able to really relate to any clinical setting or therapy response, but the gene amplification may accompany the skipping mutation, or it may only be a skipping mutation. The response to amplification without skipping mutation is still being evaluated, and there may come a day where we'll have a cutoff of how many copies of MET we need in a lung cancer sample to think the patient could be benefited by anti-MET kinase inhibitors, which of course began with crizotinib, a MET inhibitor that became an ALK inhibitor, but now has progressed to two new ones that are both approved on different sides of the Atlantic Ocean. The first one, the second one was the capmatinib, Tabrecto, which was approved in the United States by the US FDA, showing a nice waterfall plot responsiveness of the MET skipping mutation, exon 14 skipping mutation, to this tyrosine kinase inhibitor. And then prior to that, a few months earlier in the EMA in Europe, tipantinib was approved, the Merck Serono drug, also for MET exon skipping mutation with a similar waterfall plot. So both of these drugs are approved, one in the US, one in Europe, for patients with this alteration, and it can be detected with the FoundationOne liquid CDX test. So to summarize, you can use this test to not only diagnose primary targetable mutations, but also to detect the acquired mutations that occur when patients are being treated with targeted therapies. And here's a list of all of the variety of different mutations that can be detected that have been linked to resistance. Not only the T790M for the EGFR driven, which of course is almost half of the cases, but many others, including what's not spelled out very carefully, the gene fusions in genes like BRAF and ALK and ROS1 that sometimes explain the acquired resistance to a tyrosine kinase inhibitor. MET amplification, HER2 or ERBB2 amplification are major resistance, acquired resistance mutations for patients on targeted therapies, and the liquid biopsy will detect them. There are tumor agnostic approvals going quickly, and you're familiar with the NTRK approvals, of course. They're extremely rare in non-small cell lung cancer, less than 0.5%, maybe even less than 0.25%. But when they're detected by liquid biopsy, patient responsiveness to the NTRK kinase inhibitors, such as larotrectinib, waterfall plot shown here that you're familiar with, or entrectinib, the Roche drug, similar waterfall plot effectiveness when an NTRK fusion alteration is identified. If it's not a fusion alteration, amplification or base substitutions in NTRK 1, 2, or 3 are not proven right now to be targets of the anti-NTRK drugs. Only the fusion alteration is approved and expected to respond. So I'm trying to get to my key takeaways here. The liquid biopsy expands on the tissue biopsy. It's a similar test with sensitivity. It has the ability to detect both primary mutations that can be targeted, immunotherapy-based tests like TMB and MSI, and also resistance mutations that acquire during therapy. They can be complementary. The liquid biopsy can follow tissue biopsies to detect the development of resistance mutations. And when used together, they offer the patients the greatest opportunity to have a very personalized and precision treatment for their non-small cell lung cancer disease. Now, I brought along a couple of quick case reports I wanted to share with you, and then I'll be finished. A lot of patients can benefit from this test, especially when tissue biopsies are either unavailable, can't be done because of safety, or patients whose disease is progressing rapidly and a result is needed immediately. So here's the first, a 53-year-old woman who's a lifetime non-smoker who had a sample sent and found to have an exon 19 deletion on tissue-based testing. She responded well to erlotinib for a period of time, but after a year, the tumor was regrowing and her symptoms kept expanding, and a mass developed in the adrenal gland. A liquid biopsy was done, and it showed an acquiring RB1, retinoblastoma 1, RB1 gene mutation. We saw that first and said immediately, this is a transformation of a pulmonary adenocarcinoma into a small cell undifferentiated carcinoma histology. Probably 10% or so, maybe as high as 15% of EGFR targeted therapy resistance is due to small cell transformation. And on the panel on the right, we see the adrenal biopsy showing classic small cell undifferentiated histology and no resemblance to the primary adenocarcinoma that yielded the original EGFR mutation. And my second case quickly is a published case we did on an acquired ALK fusion as a resistant mutation during anti-EGFR TKI therapy. This patient was also on erlotinib. And curiously, we detected the acquisition of resistance both in a liquid biopsy of blood and urine in this patient. And this was the acquisition of an ALK fusion, not present in the original lung cancer tissue test that showed the L858R EGFR mutation, but a new mutation, a PLEKHA7 ALK fusion. This is known to confer resistance to anti-EGFR therapy with osimertinib, and the patient was placed on alectinib to target the ALK fusion and showed a substantial response. So we got the patient to respond again to targeted therapy after the osimertinib anti-EGFR therapy had stopped working. And here is the clinical photos that was in our publication showing the impact of adding the new anti-ALK alectinib to the patient's osimertinib after we detected in a liquid biopsy the presence of an ALK fusion as an acquired resistance mutation. And that's my final slide. I hope there's time for a few questions. I went a little longer than I'd hoped, but it's been an absolute pleasure to have a chance to speak to the group today.
Thank you very much, Dr. Ross. That was really, we were spellbound. I'll hand over to Dr. Vineet first for his comments and questions, and then we'll take it from there.
That was a very, very comprehensive talk on the liquid biopsy and the basic concept of circulome. That is the basis of liquid biopsy, as Dr. Ross has alluded. And also, he has nicely mentioned that, you know, you have a real-time monitoring possible whenever you do the liquid biopsies, which of course, wherever you have doubt, you can confirm with the tissue test. And of course, he said that the tumor mutational burden, which may be high, may not necessarily translate into MSI always, not universally. Sometimes there might be a discordance. I just wanted to ask Dr. Ross, how good is urine as a sample in liquid biopsy, you know, as regards yield or positivity or sensitivity? Is it as good as the other samples, or there is a discrimination?
We don't think that urine can replace plasma for patients with stage 4 cancers Where it works well is when patients have genitourinary malignancies, urothelial bladder carcinoma. We can get a DNA sequence from the urine without having to get some type of transurethral biopsy of the tissue. But if it's not a urothelial cancer, or some renal cell carcinomas have worked well with urine as well, it's going to have a very low yield. The amount of DNA that filters through the kidney and comes out in the urine is minuscule. CSF, on the other hand, is very effective and useful. Of course, it's an invasive procedure to get a sample, but for many brain tumors that don't liberate enough DNA into the blood and to be able to have an assessment, a CSF sample may be very, very helpful there.
This lady which you had shown in the second case report, a urine analysis sample had been done.
Yes.
CA lung. So how do you choose that apart from urothelial patients?
It wasn't our choice. It was a project with the patients.
Okay.
Clinical service, and they.
So I was wondering that apart from urothelial, how come in lung you chose a urine sample?
That's right. We didn't choose it. The clinician asked us to do both, and we agreed to do it. We don't encourage it, but we will do it either for research studies. But if we get a sample, and we will test it if the clinician can explain to us why. It's obviously a deviation from our FDA approval, so we essentially have to call it for research use only. The FDA approval for F1 liquid CDX is for plasma only. It is not for urine or CSF.
Sure. Nitesh?
Thank you. I know we are pressed for time, but there's a very important question that I've been meaning to ask. There are times when you have a patient who has a Foundation 1 CDS at diagnosis, let's say a stage 2, stage 3 tumor, and he ended up with a Foundation 1. And then as recurrence happen, we don't have a solid tissue, we do a liquid biopsy, and the mutations change. We had a patient with a BRAF non-V600 in the primary sample, which got lost in the liquid biopsy with a gain of a RAD54L. So which of those two mutations is most likely to be used for therapeutic benefit?
I think that's an absolutely critical question. There's no question that the alteration panorama can change over time. The liquid biopsy's biggest advantage versus the original tissue is that it's time current and reflects what therapy the patients received up to that date. Now, there is some question about whether the liquid biopsy will falsely miss alterations for one reason or another, and that can always be possible, but it will also pick up alterations that a tissue biopsy might not find because it's a pooling of all the metastatic sites. So the tumor heterogeneity, which we read so much about, is very much solved by the liquid biopsy in many cases. The brain metastases may have KRAS G12C that we wouldn't have found if we had done the liver biopsy, but yet that therapy may still work for all. So we're very encouraged by the liquid biopsy's ability to detect the treatment most relevant mutations when the test is successful. But there will be false negatives on occasion. When we look at pancreatic cancer, for example, well, we know that 90% of the tumors have a KRAS mutation. It's just been known like that for decades. But when we look at the liquid biopsy data published and day to day, we don't get anything near 90% KRAS mutations. Why do we find less in the liquid? Well, we're not completely sure, but it's certainly something that's been observed. So it's a learning curve. We're learning this together. And when the two don't agree, we'll always say, well, therapy could be a reason to explain it. Some clones successfully eradicated by therapy and that particular mutation disappears, and sometimes not. As you know, with EGFR, we usually continue to see the primary mutation even after T790M develops, but in some cases we don't. We lose the primary mutation and only have the T790M. And that's true whether we do a metastasis biopsy and sequence that, or we do the liquid biopsy. So we're learning, but there's going to be discordance, and some of it's going to be biologic and some of it's going to be technical.
Excellent. Thank you very much. I think we would have loved to have another hour of chat with you, but we can't. I must thank you from all of us and the organizers for being a part of this. Really must. And
Thank you
thank you,
very
Dr.
much.
Vineet Talwar, for
I
chairing.
hope next year I could come to India to give a presentation.
I'm sure we will do that. Thank you.
Thank you.
With that, and I think that was so exciting to hear, Dr. Ross. I go on to the next session. We have Dr. T.P. Sahu, one of the best speakers in India, and he will be speaking about first-line chemotherapy for adenosquame and adenosquames, and really does the biology matter. Dr. Sahu, over to you, sir.
I would like to share my screen.
So you will be able to do it now, sir. Try it.
Okay, I'll do it now. Okay, it's
Yes,
visible.
we can see the screen. Yes, very much.
So thank you, Nitesh, and thank you. I think I'll save you some time here, and this is a topic which I first got, and I thought, what new, and what do I have to say that all of you don't know? And this is a topic that was told that is this the jumbling of words, or this is something beyond that? So I have to speak for the next 10 to 15 minutes on the first line chemotherapy in adenosquamous and squamous. So my point here is to look at the peculiarity of the adenosquamous, which few of us have theoretically know, but very few actually know what exactly to do and how to go around it. And in the last part of my 4 or 5 slides, I'll go to the classical things, how we stick to and would like to treat on chemotherapy. For starters, I would like to put up very clearly that I'll be restricting my talk to the chemotherapy part of it, and probably adding on the immunotherapy on the first line, and I would not dwell beyond the first line. So if you look at it, this is how the lung cancer histology looks like. We heard a very nice talk by Dr. Roche, and we heard about the liquid biopsies. I go back probably 20 years back now. And this is where it has been all about small cell, non-small cell, and we have been taught about to go beyond that to adenosquamous and large cells. And if you look at it, there is a percentage of around 0.4 to 4%, which is actually eluded in the literature. It's very variable. And if you look at the first adenosquamous carcinoma was documented, the classification came into in 1978. It came from the Japan Lung Cancer Society, and it was looking at the component of squamous cell and adenocarcinoma, and they told at least one of them should be, each of them should account for 20% of the tumor. Go ahead, 3 years after, then they told that a diagnosis could be established as soon as you look at any component, the percentage just went off. And then there was a thing in 1985 that looked at that it could be based on corresponding typical characteristic which you find, maybe a keratin for a squamous cell or a gland formation in the adeno. But you come back to the WHO 1999, and that really stands till now, is that you should have at least 10% of the tumor under the light microscope. And this word of light microscope is important, but if you look at the electron microscopy, then this percentage of adenosquamous can go up to as high as 40%. So it's under light microscope, and each of the components should be at least 10%. A squamous, adeno, the other one could be major, one could minor, but at least 10% of the tissues should be at least adeno and squamous. And if I look at it, this is how a differentiation looks like for the mutation things from adenocarcinoma. You look at the EGFR, there have been very contrasting data for that. You do find literatures which also tell that the mutations, at least the EGFR in adenocarcinoma and adenosquamous, match each other to 30 to 40%, but there are literature which tell that the mutations which you look at, EGFR especially, is much more common in adeno, then little lesser in adenosquamous, and much lesser in the squamous, around 4% that we know. But this is the thing, the consensus is around 30 to 40% adenosquamous would have a mutation that's around EGFR. They would have a 5 to 6% of an ALK mutation. The KRAS is little higher to 10 to 11% in contrast to the adenocarcinomas. The glandular component also decides upon the extent of EGFR mutation. The more the amount of the adenocarcinoma component, the more likelihood of getting EGFR mutations or other mutations as we normally see in a adenocarcinoma typical. Look at the prognosis, and that the prognosis is more documented in the operative setting. And they looked at it at the operative setting, and they found that if you have adenosquamous, they probably do much worse than if you have a pure component. And that's where I stopped. The green line is a classical adenosquamous. There are other varieties. I'll stick to that. The take-home message is the adenosquamous normally have a poorer prognosis. And look at how we do. If I get adenosquamous, it's important that we diagnose it and what to do. Should we be starting chemotherapy? No. The first step what we should be doing in adenosquamous is we should be looking at the mutation analysis, send for a mutational as you normally do for your adenocarcinomas or a typical selected squamous cell, but you have to do a mutation because it is documented that around 30 to 40% would have some form of mutations which might alter your treatments. And the responses, if you look at adenosquamous, that's this part of it, then the adeno and then the squamous, the responses really match the adenocarcinoma. The basic point which I want to make is the responses on the mutation, if you find, or normal responses to therapy in adenosquamous actually matches more of adenocarcinoma and lesser to the squamous cell carcinomas. Even the median PFS is matching the adenocarcinoma. This is one of the first trials that was published for the adenosquamous, the largest group that published the effect of gefitinib and erlotinib. Now we come down to how they do. Yes, all of us know that the patients who have mutations do better, and that's the same thing that is happening. What happens to the PD-L1 expression? The PD-L1 expression, as per the literature which I could gather, is actually correlating and matching in contrast to the components on which you do the mutation. The adenocarcinoma of the adenosquamous match the adenocarcinoma normally what you see, and the squamous cell match the PD-L1 expression what you see in a squamous cell. So this is the adenosquamous. The take-home message should be here that you do for mutations. If you have a mutation, work as you do for a when you get a driver mutation. Otherwise, you choose chemotherapy. What chemo to choose, that would not be a consensus. What I would probably do is I would do something that works in both squamous cell and adeno. You could go for a taxane-based chemotherapy, excuse me, or you could probably go for a gem carbo, which probably doesn't work that good in adeno, but at least works. I would prevent myself from going from a pemetrexed-based chemotherapy. So now looking at the other parts of non-small cell, it started, we know 1990s, there are a lot of articles. We had all these articles telling you that Paclitaxel became the standard of care in a publication in 1990s, and that showed that it was equal to vinorelbine and cisplatin. But this became the treatment of choice because Paclitaxel was well tolerated in contrast to vinorelbine and cisplatin, and the disease progression and everything matched. But the therapy completed, if you look at Paclitaxel, was much better. It was much better tolerated. Toxicity was better. That's how Paclitaxel became a standard of care, which till now has been. Which chemotherapy has been better? Then the trial came, and this is the ECOG, which told you that anything with a platinum, actually a Paclitaxel, a GemCis, or a Docetaxel, or a Paclitaxel do not matter. Everything actually matches, and the ECOG told you that every line graph matches each other. Then came this trial in 2008, and this really showed us the pathway that adeno and non-squamous and adeno should be treated differently. This is the JMDB trial, and all of us know this trial. The main intent of the trial was to show the non-inferiority. It did not. The pemetrexed platinum matched the gem platinum, but when it came to the histology, we saw that the non-squamous did better with the pemetrexed arm, and the squamous did better with the gem arm. Although it was statistically significant, but the absolute values may not be huge, but definitely the curve was separating for the histologies. And that's where in 2008, the whole thing started. The Paramount study, we know now that we need to do a maintenance if you're giving chemotherapy first line. Now coming to the last part of my 2 slides, if you look at it, what more? We were really plateauing off beyond the maintenance. In 2012, we got the maintenance study till the immunotherapy came in. And this has been a very diverse. I put up on this slide to look at on a concise what we do, because we have spoken so much about it. These 3 trials, the Keynote 024, Keynote 042, and the Checkmate 026, looked at non-small cell lung cancer. They took both of it. If you look at this, the squamous cell alone was taken up only in 1 trial, that is Keynote 407. And the non-squamous was taken in for the Keynote 019, which is the most famous trial we always quote. The IMpower 150 and the IMpower 130, they looked at only non-squamous. That ISO has probably data more for the non-squamous. And what the data is, If you look at the non-small cell where they looked at only the PDL values, not at the histology, we found that we all know these trials to tell you that addition or alone immunotherapy beyond a particular PDL values of 50 has made a significant difference. All of us have been doing that. What strikes me in this is that this squamous cell, if you look at Keynote 047, the median OS was much inferior if I look at in statistical terms, in contrast to the non-squamous. The non-squamous in the PDL1, and if chemo is used with immuno, the absolute numbers of the survival actually looks much better. But all said and done, the only trial which we have in the first line for squamous, Keynote 407, did show an advantage of 15.9 versus 11.3 to combine the immunotherapy with paclitaxel arm. So to conclude, adenosquamous is an uncommon histopathological diagnosis. It is around in 0.4 to 4% of the literature that has been there, usually associated with a poorer prognosis, should undergo mutation analysis. That's my major take-home message. Otherwise, chemotherapy is the mainstay. I would stop myself from using pemetrexed-based chemotherapy. Probably go for a GEM or a paclitaxel. That's one more important thing is when the adenocarcinoma squamous is there, they metastasize, and the metastasis could be of pure histological variety, single type. Means you could get a metastasis of pure squamous or adenocarcinoma. That you have to remember. The metastasis may not be necessarily a mixed histo. In non-small cell, we drive a mutation for that. I mean, total, it is targeted therapy. Sorry. Otherwise, this is what it is. You do the molecular testing. If you have an oncogenic driver, you do it. All of us know that. If you don't have, we today in affordable class, we look at PDL values. We look at single agent pembrolizumab, or we look at chemotherapy plus immune checkpoint inhibitors. For majority of Indians, still this is out of the reach, and still chemotherapy followed by chemotherapy and some form of chemotherapy is the way we go ahead. And that's what my final take will be. And thank you organizers. Thank you, Nitesh, for giving me the opportunity. Thank you.
Thank you very much, TP. As usual, I think you make some very complicated topics very simple. I tried to make it very complicated, but I get your take-home message. Adenosquame is not an adeno, it's not an squame. It is actually an entity by itself. And I agree, when confused, I think chemotherapy remains our backbone, which works, and done well, people tolerate it well too.
Yeah, and the only thing is, I hope I could deliver what you wanted me to deliver. That's
absolutely. That's exactly why I think we were trying to get that message across, because this is not uncommon with small biopsies. Not uncommon to actually have mixed tumors histology.
Yeah.
Paucity of time, we would have loved to ask you many questions, but thank you very much, Dr. Sahu, for this wonderful talk.
Thank you.
We'll move over to our next very important session. Thank you, AstraZeneca, for sponsoring and supporting this conference as well as this session. We have one of my very good friends and a wonderful speaker, Dr. Daniel Chan from, I would have to love to say all the way from Singapore, but he's not here in person, but still all the way from Singapore. And he has some phenomenal insights into medical oncology as a whole. I'll pass over to Dr. Advani, who is the chair for this session. We'll have Dr. Daniel Chan speak about his experience on durvalumab in stage 3, followed by Dr. Bharat Vaswani, who's going to speak about ADAURA. Dr. Advani, sir, could you please take over? And Dr. Daniel Chan, could you please start your presentation?
Yeah, good evening. I think it has been... Hello?
Yes, sir, we can hear you, sir.
Yeah. Good evening. I think this is a real good opportunity for all of us to now listen to the next presentation by Dr. Daniel. He is from the Singapore Mount Elizabeth Medical Center, and he is going to discuss with us the experience sharing on durvalumab for the management of stage 3 unresectable non-small cell lung cancer. As all of you know, that there's a tremendous interest in the immunotherapy as it is happening now, and I think these newer approaches are going to pave the way for the newer and newer improvements. So with this, I would request Dr. Daniel to start his presentation.
Hi, good evening. I would like to thank the organizers and Dr. Nitesh especially for inviting me to speak at this event. These are my disclosures. So I was indeed in New Delhi about 5 years ago when I met Dr. Nitesh. I was there to talk about immune checkpoint inhibitors when the data was just coming out, and many people were still wondering, is this all a myth? Can immunotherapy actually treat lung cancer in a metastatic setting? But well, we now know that we are way past that point. We're not even talking about this in stage 3 disease and maybe even some neoadjuvant approaches. I would love to have come back. I couldn't have any chance to go to the Taj Mahal the last time round because I was worked too hard by Dr. Nitesh. So I hope I'll be invited back in the future. So I think we can all argue till the cows come home, and perhaps many views in a room of 100 doctors, we had 200 views about a single station N2 disease, but that's not the purview of today's talk. It will be the multi-station N2 disease, where we've all agreed that concurrent chemoradiation is the standard of care. And we know that in recent TNM changes in the 8th edition, we know that size does matter, and some of these patients who have otherwise be a T2, they're actually upgraded to a T3. And for example, 5 to 7 cm now T3, and more than 7 cm is a T4. And we can see that the bulk of the stage migrations with the 8th edition is actually due to the size changes, although there's some other changes due to things like T3 diaphragm now being a T4. So I think for concurrent chemoradiotherapy, much has been done, much has been said and argued about what is the exact chemotherapy backbone we should be giving: cisplatin, etoposide, carboplatin, paclitaxel, cispem. I think this really just puts everything into perspective that the immune checkpoint inhibitors, durvalumab, adjuvant post-concurrent chemoradiation really was the biggest change, the greatest landmark development in the stage 3 setting for non-small cell lung cancer. So we look back at really old publications. This is from the year 2002, Kathy Albane, the SWOG study showing cisplatin etoposide, extremely toxic regimen. And we'll try to improve on this. Walter Curran and colleagues, carboplatin paclitaxel, much better tolerated. Sometimes we'll even split it into a weekly dose. And more recently, the PROCLAIM trial of cis-pemetrexed versus cis-etoposide, even though the trial was stopped for not really meeting its primary goal, but it's generally deemed that this is roughly equivalent to cis-etoposide. So I think really it doesn't quite matter which approach you go with, as long as the patient gets concurrent chemoradiation. And we know that this is the preferred approach because Walter Curran showed that concurrent approach is actually superior to that of a sequential approach. So, after this, various strategies were tried, trying, to add some chemotherapy before concurrent chemoradiation, trying to have surgery after concurrent chemoradiation, or even adjuvant treatment post CCRT. So another study by Everett Vokes, in short, introducing chemotherapy before CCRT showed no benefit. The two curves, the Kaplan-Meier curves, hug each other. And how about Kathy Albane's intergroup 0139 trial? Well, we know this is a positive trial, but this is only on the assumption that the patient undergoes a lobectomy and not a pneumonectomy. And this is something that is a little bit difficult to really predict. And a lot of my surgeons are still quite worried about operating after concurrent chemoradiation. Which brings us now to the last category. We couldn't get much benefit in putting stuff before CCRT or surgery after CCRT. How about using systemic treatment after CCRT? So the Hosier Oncology Group did a trial of consolidative docetaxel after CCRT with cis-etoposide. No difference at all in the PFS and the overall survival. And the SWOG group did a trial of maintenance gefitinib or placebo after CCRT and docetaxel consolidation. And wow, okay, we see a difference. But look, it's the placebo that's on top of the gefitinib arm in the overall survival. So it's deleterious, and the PFS was the same. So I think everything was really pretty much in the doldrums for stage 3, and everyone was very disappointed until, in 2017 in ESMO Congress in Madrid, the initial data of the Pacific trial, which is double-blind placebo-controlled phase 3 study of durvalumab after concurrent chemoradiation in patients with stage 3 locally advanced unresectable non-small cell lung cancer. So I think everyone's familiar with this protocol. Patients randomized 2:1. Durvalumab after concurrent chemoradiation had to start within 42 days or else placebo. And this is really laudable that they actually had a placebo arm for this for the duration of 12 months. Primary endpoint was PFS, secondary endpoints response rates, duration of response, and also overall survival was a co-primary endpoint. So we look at the patients, they are really our typical stage 3 non-small cell lung cancer patients. Majority of them are current or former smokers. Overwhelming majority of patients in this trial were stage 3, A and B. What I found was a bit more interesting, or there were a bit more non-squamous than squamous. PD-L1s, about a third are unknown. And about the usual, a quarter being on the high side. Radiation, the bulk had the standard dose of radiation. We know that doses above 60, 66 gray really do not have much benefit. And the bulk of the patients actually had a PR. So we know that the patients in the two arms, right, approximately 42.7% of them completed all 12 months of treatment versus 30.1% of placebo. So you can get at least about 40% of patients who finished the treatment. And the patients could actually receive subsequent treatment after discontinuation, about a third of them, as compared to 43% with the placebo. So we look at the progression-free survival curves. We can see that at the landmark time points of 12 months, it's 55.9% versus 35.3%. At the 18-month mark, it's 44.2% versus 27%. And as you all know from the prior curves, this compares much, much more favorably as with prior data. So we look at the forest plot. We can see that virtually everybody benefits. EGFR status, a very common question at all international meetings. Very, very small numbers, very wide confidence interval, but still seems to land on this side favoring durvalumab. And quite interestingly, PD-L1 status does not seem to predict who will benefit, because whether be it high, low, or unknown, it all falls nicely on the side of durvalumab. So we know that the benefit of giving the durvalumab is not just confined to being a radiosensitizer. We find that there are distant metastases, like in the brain, in the liver, for which it's lower, and durvalumab compared to the placebo. So this is not just a radiosensitizer. And the distant metastasis of death, again, it favors durvalumab versus placebo, 23.2 months versus 14.6 months median. And safety for grade 3-4 is actually comparable to that of placebo. And for discontinuation, yes, about 50% more discontinuation in durvalumab than placebo, but still at relatively low levels. The common AEs would be that of cough, pneumonitis, some pyrexia, some rash, hypothyroidism. But we look at the grade 3-4 clinically significant, actually it compares quite favorably with placebo. Radiation pneumonitis, which is always a very feared thing. Any grades are numerically high in durvalumab, but for clinically significant, just slightly higher. And for actually grade 5, which is death, it's actually comparable. So I think at ESMO, there was a critical and landmark finding that this was the first time that you could actually get a PFS improvement in this population where virtually every other strategy other than concurrent chemotherapy had failed. And the overall response rates of 28% versus 16% was something that hadn't been achieved before. At that point in time, the overall survival was still blinded, but we really noticed that even distant metastases were impacted. So about a year later, in New England Journal of Medicine, Antonia and colleagues report the overall survival, and we can see that the median overall survival at 24-month mark, we hit about 66.3% versus 55.6%. And this is, of course, much better than historical. So now I'll show you my patient who was in the early access program of durvalumab, 65-year-old Chinese gentleman, heavy smoker, COPD, FEV1, FEV6 15%, poor effort tolerance, left lung, NSCLC, squamous cell carcinoma, 8 addition, T3, 5 to 7 cm, N1, M0, stage 3A, non-small cell lung cancer. He had 2 cycles of cisplatin, gemcitabine, could not tolerate any further chemotherapy, and moved him on to sequential radiotherapy. And he had 1 year of adjuvant durvalumab. This was a scan initially from China, showing the large mass and also the hilar lymph node. This was his residual mass, FDG uptake after chemotherapy, followed by sequential radiotherapy. And this was midway through his durvalumab. You can see that it's virtually resolved. And this is after completion of 1 year of durvalumab, you can see some really linear plate-like atelectasis consistent with the radiotherapy fields. Otherwise, he's well. You can spot a little inhaler back there because he's got very, very bad COPD, but he's given me his consent to show his photo, tell people about how great this drug is. And with that, I'd like to thank you for your attention.
Thank you, Dr. Daniel,
Excellent.
for a nice presentation of utilizing the durvalumab in the unresectable stage 3 non-small cell lung cancer. And I think the question and answer are going to be later on.
So we will just ask one question right now, and then we can go on to Dr. Vaswani. It's a question which was coming even before, which is that with 3 years overall survival data, is it adequate? Because we do know that although it is positive, we do know that immunotherapy in second line also may have a few years to add.
Yeah, so Dr. Nitesh, thanks for always asking the most difficult questions. So I think this is something that we are all struggling with, not just in lung cancer, in the PD-L1 sphere, but also in the EGFR TKI sphere. You know, even we were grappling with these issues about maintenance, Alinta, and even in some other cancers, which is that are we merely just bringing forward, you know, bring it earlier, the subsequent treatment, and, you know, A followed by B when you need it versus A followed by B immediately might in the end show no difference. I think we would need a randomized trial with that kind of a strategy. Unfortunately, I don't think that is going to happen. But what we do know is that a lot of patients fall off quite rapidly in the first 2-3 years. And I think it's this group of patients that we are trying to catch. So I think that it's still a reasonable strategy to give, you know, adjuvant durvalumab after concurrent chemoradiation for stage 3 non-small cell lung cancer, particularly if they are fit.
Excellent. Thank you very much. Dr. Advani, over to you, sir.
Yeah, I think now we'll move on to the next presentation. Our friend Dr. Bharat Vaswani, a senior medical oncologist from Yashoda Hospital, Secunderabad, is going to talk to us on the adjuvant therapy of EGFR mutated patients with EGFR inhibitors. So I think over to Bharat Vaswani.
Thank you, Advani sir. Your words are always a blessing. Thank you, Nitish sir. Now, the topic that I am discussing today actually has been discussed in lot of forums for the last 6 months. So when I got this topic, I thought, what would I discuss again? But then what we heard in the last 10 days is there is again an exciting data in continuation of what was presented in ESCO, was presented in this ESMO 2020. Secondly, we had a full text presentation in NEGM in this September edition. So I got a lot of things which I could clear some of the confusion. And I requested that people to give me the topic as ADAURA revisited. So I'll be trying to clear some of the doubts and I'll be happy to take the questions afterwards. Now, what we know from the metastatic setting is first line EGFR TKIs are better than chemo as per as the results of IPAS study, your tech study. Second thing we know is in a second line setting, in a T790M mutation, osimertinib is better than chemotherapy.
Bharat, your slides are not moving. If you try to move them.
Yeah. So the third thing that, sir, I did not start, I was just trying. And the third thing is what we had in a FLORA study, the third generation EGFR TKIs is better than first generation. So by taking a more effective drug in an early stage lung cancer, can we cure more number of patients? That was the main thing why this study was done. Now, all of us know that around 1/4 of the patients of non-small cell lung cancer are resectable. When we define resectability is stage 1, 2, and 3A. 3A including N1 or rarely single station N2 and rarely discrete N2, but that is a controversial topic. What we also know is surgery is the primary treatment in the early stage non-small cell lung cancer. When we give chemotherapy, as per as the meta-analysis, there is a reduced risk of death by 11% and there is a reduced risk of progression by 16%. But to top it all, even with the best and best of treatment, the recurrence is still half of even stage 1B has a recurrence. But if you say stage 3, 3/4 of the patient will recur in spite of the best treatment. So you need more than a chemo to cure or to increase the cure rates of these patients. Now, if you look into all the guidelines that has been done, there is no guideline which suggests that you should start doing molecular testing in early stage lung cancer, except for some guidelines from China where there is a lot of research done. But so far as now, still curable, what we say, resectable, no molecular testing, chemo plus minus. Now, if before going into the landmark trial, there are 5 trials which have discussed this concept. If you look into the center, Radiant and BR19, these were trials we should not discuss because the population selected were unselected or amplified EGFR. So the discussion may not hold true. 2 remaining trials, Select trial and Evans trial, were a phase 2 trial. They never looked at DFS. The main purpose was to see the overall response rate and maybe a DFS. And the only worthwhile trial that has looked into it is a adjuvant CTOM study. All of you know that there was an enthusiasm with the study with the improvement in DFS, but unfortunately in this ESCO 2020, the OS was not significant. Hence that enthusiasm basically was partly diminished. Now, if you look into the data that has been presented before this study, 2 studies, adjuvant and EVAN, if you see, adjuvant no OS advantage, Evans there is definitely a very significant improvement in DFS with the hazard ratio of 0.26. But so far as now, because there is only a DFS but no OS advantage, all the guidelines, all these studies have not translated into anything in clinical practice. So let me come to the blockbuster trial, that is AD-AURA, so adjuvant AURA. Osimertinib as adjuvant therapy in patient with stage 1B to 3A EGFR mutation positive NSCLC after complete tumor resection. So a phase 3 double-blind study in which patient with 1B to stage 3 completely resectable patient with or without adjuvant chemo. Only trial which has included till now both the patient was stratified to receive osimertinib in the ratio of 1:1 to placebo. The most important thing was adjuvant treatment of osimertinib was given for 3 years. Unlike previous study of CTOM where it was given for 2 years, and I tell you, this is most important here. The primary endpoint was DFS in a high risk stage 2 to 3A. And if you look into it, their expectation was a DFS of 0.70 and what we got was far better. The other endpoints were OS and quality of life. So if you look into the baseline characteristic, 2 things important. Stage 1, 2, and 3 were equally distributed. Around 45% of the patient did not take chemo, and that was given in test. These 45% of the patient were stage 1B mostly, and some patient in stage 2, which otherwise also we may not give chemo also. So whether you should give chemo in high risk, the answer is yes, still now you should give it, but post chemo you should give this drug. Now, when you come to the primary endpoint, which was the most important thing, disease-free survival in high risk stage 2 to 3A. Now, if you look into the absolute number at 2 years, it is twice the absolute number. You never think of absolute improvement from 44 to 90% with a highly significant hazard ratio of 0.17. So 83% reduction in the risk of recurrence at 3 years, if you say. So that is something which was never heard of. If you look into the overall population, including stage 1B, this ratio continues to be 0.21. In my 12 years, I have never seen a lung study which shows such a good hazard ratio of 0.21, even in a low risk included patient. Now, when you look into the subset analysis, what you see is stage 2, 3 outscores over it. But if you see stage 3, this hazard ratio, so there is an improvement by 88% in terms of reduction in recurrence. You give chemo, you don't give chemo. So probably the advantage remains the same. Again, questioning whether you really require chemo in early stage CA lung, or you may directly put on this drug once if it gets validated and approved. Just see the results of placebo. As expected, stage 1B, 73% had relapsed by 2 years, and in stage 3A, nearly 32% were only person who were disease-free. But if you look into the upper part of the curve, stage 1B, stage 3, the DFS remains the same, 88%, further emphasizing the way that if it is more high risk, this drug works better or as good as what it works in other subset of patients. Early survival data, probably at 2 years, you cannot comment because the events were very low, only 3% in osimertinib and placebo, only 7%. Now, this was something which has again reinforced my belief that it may turn out to be a positive study. Now, if you look into the recurrence, there were 11% recurrence in osimertinib arm versus 46% recurrence in placebo arm. When you subdivide it, majority of the recurrence in osimertinib were local, see a blue, and majority of the recurrence in placebo were systemic. And you know systemic is much worse than local. You have local salvage therapy for controlling these symptoms. So the recurrence pattern were different, again telling us that probably it reduces distant recurrence better. Now the most important thing, if you look into the recurrence, the commonest extra, lung recurrence in previous studies also was in central nervous system. So here you find only 4 patients, that is 1% patient in osimertinib arm had relapsed in the brain versus 33 patients, which is 10% in the placebo arm. If you remember your CTONG study, 37% of recurrence were in CNS. So again, telling that this drug will work better in CNS, and that drug did not work, and probably that was the main reason that drug failed. Now coming to number of events, what I told you, 4 were, that is 1% versus 33 patients versus 10%, which is quite a high number. Now, if you look into it, the decrease in recurrence in CNS, again, this hazard ratio is 0.18, so 82% reduction in risk of CNS recurrence when you give osimertinib in an adjuvant trial. Again, this difference is going on increasing. In absolute 16% improvement in terms of CNS at 3 years. Every good thing may have a bad thing. So again, you have to remember 2 things only. What was grade 3? 20%, so 1/5. But more importantly, even after giving 3 years of this drug, only 11% had the drug discontinued. Again, telling us that with the longer duration of time also, this drug has worked well, and majority of the patients are able to tolerate this drug well in the clinical setting. When you look into the grade 3 side effects, diarrhea, we know, some nail changes and some upper respiratory tract infection, including nasopharyngitis, upper respiratory tract, some appetite loss. 2 things which I have seen lot of people discuss about is interstitial lung disease. Only grade 1, 2, that too only in 3%. QTc prolongation less significant in 7%, but this did not lead anything to disease or a drug modification. So a very safe drug in practice with a long duration of it. I'll go back to my first slide which has told, and I'll put this again. So again, if you see, this has definitely outscored other drug in terms of hazard ratio. And I'll be telling in the next slide why I think this it was important. 2 studies only in a phase 3 setting which has done an adjuvant thing. One was a adjuvant CTONG study which we had seen, and this is AD-AURA study which we are seeing now. A very big study, 682 versus 222 patients. If you see, the main difference is 3 years of osimertinib. If anybody remembers CTONG study, those patients who could take 18 months or more than 18 months of geftinib had an improvement in OS. And here we are giving a drug for 3 years. So a durable response is expected. Now, if you look into 3 years landmark, the DFS is twice what was there in gefitinib adjuvant study. So the first landmark, it has already outscored by twice. Definitely we need to wait for OS, but I am more enthusiastic for this disease. Disease activation equal, serious adverse event negligible. So my take on AD-AURA study, probably this is what you should also ponder about it is, osimertinib and ADAURA will outperform data of the first generation TKI from earlier trial because of the three major things. We all know that its potency for mutant EGFR is far better than the EGFR TKI, and probably it will kill more residual tumor cell if any present. ADAURA is using a longer treatment duration of 3 years, in contrast to the previous phase 3 study. And we have a data to suggest that longer duration of gefitinib in that study had led to the overall survival advantage. And the most important belief, which has been proven now, is that it has a significant better activity in CNS. So we will have fewer CNS relapses in this. And we have already seen that the biggest failure in GTOM study was in CNS. So this also is a positive point. So if I have to summarize, adjuvant treatment till now continues to remain chemo with or without radiation. Previous clinical trials prior to this landmark study in the adjuvant setting showed mixed results, but promising, of course. But again, which it showed a DFS improvement, but no OS improvement, and it continues to remain same. But if you look into the ADAURA trial of adjuvant osimertinib versus placebo, it was unblinded 2 years before it was supposed to be unblinded in February 2022, but it was unblinded in 2020, only to us, not to the patient. So they are still not knowing in which they are. And probably in the next 1 or 2 years, because you have 2, 3, 4, 5 year DFS, it will answer many of the key questions. And I believe this trial will be positive. So rather than you asking me, I am asking some questions. Based on this study, probably you should start doing this mutation test in early, maybe not in 1B, but maybe in 3A, because that is somewhere where you need it, because they will probably fail. Do you think osimertinib may make patients opt for it with or without chemo? How long to give is still a golden question, and the trial has still not answered what is a post-treatment, what drugs they have taken. So probably some questions answered very well, but still some question to be answered, but a trial in a positive direction. I thank you all for a patient hearing.
Thank you, Dr. Bharat Vaswani, for clearly giving a message that although the use of osimertinib does improve the disease-free survival, but it has no impact on the overall survival. I think this is very important. That's how the use of newer agents have to be based on the ample evidence. And therefore, I think this clearly shows that the EGFR inhibitor may not be all that essential as an adjuvant in the early stage lung cancer. I think both the presentations have really given a clear message in terms of using the immunotherapy after the concurrent chemoradiotherapy in unresectable stage 3, and also in the resectable stage 3, the EGFR inhibitor use. I think with this, we can allow some few questions.
Thank you, sir. Just one question which is coming through is that 2 years was a good control with osimertinib in the metastatic setting. So it should be logical that the overall survival real advantage will be seen not before 5 years of follow-up. What's your take on that?
Sir, the thing is a valid question to answer, and the exact answer we don't know. But what we know is why the thing is, where did GTOM fail? That is, GTOM fail, we need to understand about it. The main failure was in CNS. It was less potent to start with, and the recurrences were quite early. If you see, 72 patients only can go beyond 18 patients. So 1/3 had already relapsed by first 2 years, first 12 months only in CTOM study. What this study has showed you is that there is no early recurrence at all, which was there in 1/3 of the patient in the other trial. Probably where it failed was it failed more in CNS. And probably some of the data from metastatic, we may not take it into adjuvant. The thing is, this is a more potent drug in terms of its potency known, in terms of CNS known, and probably these advantages, we are now getting it in the adjuvant also. So if you look into the studies on that or head-on comparison, that drug failed very early in 1/3, and this drug has not failed at all. So probably that acceleration may not hold true in the adjuvant settings.
I think you make a very good point. And thank you very much for that. Really heartfelt thanks to Dr. Advani, and our gratitude for gracing us with the chairmanship on this session. And thank you both, Dr. Chan and of course, Dr. Vaswani, for this lovely talk. Thank you very much. With that, we'll move over to the next very interesting session. We'll have 3 talks here. We have chairs, Dr. Binu Walia, Dr. Shyam Agrawal, Dr. Ajay Bapna. And we'll start with Dr. Sevanti Limai, who's speaking about adenocarcinoma targets, cost limitations. What do we really do? You're on mute, Sevanti. We can't hear you. We can see the slide, Sevanti. We can't hear you. We can see the slides. We can't hear you. You're not audible. No, Sevanti is still not audible.
I think somebody from organizers can sort of.
Yeah, they're trying. So.
Yeah, we are calling.
So, Nitesh, if Dr. Amit is there, can we ask the next speaker then?
I think we'll just wait half a minute and see if Dr. Sevanti Limai can log in. Otherwise, it's actually Dr. Vikas Talreja because there was a change in program. You just give me 1 minute and Dr. Vikas is there. But I'll see if Sevanti can come in. Otherwise, we'll change over to Dr. Vikas. Dr. Vikas, could you please stay on standby in case we have to do that? Sonali, should we switch?
Yeah, because we are already running behind the schedule, Nitesh.
So
yeah, we're running about we are running 5 minutes behind.
Yeah, okay. Let's get Vikas.
Okay, Vikas, are you there?
Yes, sir, I'm there. Can I be allowed screen sharing, or you would be sharing my slides?
No, I think you do screen sharing. So, Sonali, could we switch, please?
You can screen share now. Yeah, now you can screen share. Yes, thank you, Vikas.
Perfect.
Excellent. Sorry about that.
Thank you, Dr. Nitesh, for the opportunity. Amazing platform and amazing audience to start with. And I will be sticking to my time limit of 15 minutes. I would request to give me a gentle reminder just before that.
I will.
And we will be starting with one of the most hot common topics as what could be the first line in a non-driver mutated lung cancer. It is a war of words, and that would be the options we have right now. The screen is short, I believe, right now, but yes, we have anti-CTLA-4s, we have anti-PD-1s and anti-PD-L1s for those students, at least to give them a view. And my talk will be very simple. We will start with where we come from. That's the chemotherapy with the baggage associated with it, where we are with a cocktail of options right now, and whom super soldiers we are going to create in future. This has been repeated since many times, and we know what has been the prognosis of the stage 4 lung cancer. And my presentation will start with a single agent therapy. We started with a very low threshold when the chemotherapy in the backbone with a median survival of around, whatever be it, we use whatever chemo combinations available on earth. The survival never exceeded a year, with less than 1/3 of them surviving over a year, with median OS with whatever beds we used was 7.9 months. And just 3 years ago, that was the ESMO standard of care. It was the chemotherapy everywhere. And we got a slightly over hyped because of the adding of angiogenic inhibitors, that is bevacizumab, and it showed, we could see through a microscope some OS benefit, some PFS benefit, but that also was varied across the trials and across the groups. The maintenance pemetrexed was somewhat also in our armamentarium for most of it. But our aim was, is, and will always be improving OS over the time. We started low with best supportive care, probably during the Advani Sir times, to platinum doublets, to anti-angiogenics with maintenance therapy, and now we have chemo immuno options throughout our armamentarium. And with the second line data, we are confident that immunotherapies do work in specific subset of the population. We now have a 5-year data of pembrolizumab as second line and 5-year OS data of nivolumab surviving in second line. So that gives us a confidence that yes, there are long-term non-small cell lung cancer survivors. And that's why which the immunotherapy checkpoint inhibitors, which has become a standard in second line non-small cell lung cancer, we now shift our gears to the first line strategy. We will be discussing the keynote trials, the Empower, the Checkmate, and some of the other trials to lay a foundation on. So the first trial where we will go is the blockbuster Keynote 42, which randomized PD-L1 more than TPS of more than 1% into pembrolizumab 200 milligram up to a limit of 35 cycles versus paclitaxel or the PEM-carbo. And the endpoints was the OS in the PD-L1 TPS of more than 50, 20, and 1%. And it 305 patients randomized over it, with 83 patients had a crossover to pembrolizumab arm on while they were on the study group, which was effectively the 66% of the crossover rate. And 52% patients subsequently received anti-cancer therapies, including 12 who received a second course of pembrolizumab. And the median follow-up was around 16 months. And baseline characteristics, as we see, were equally matched in between the two arms. And that's the most beautiful curves you can see after the ADAURA trials. 5-year survival in a stage 4 metastatic situation, with survivors ranging from 16.3 in the control arm jumping to 32%. So 1/3 of the patients do surviving after the 5 years in a stage 4 lung cancer, where we started with the backbone of around median OS of 8 months and less than 1/3 even making up to the first year mark. Now we have a 5-year survival of 32%. That's a remarkable figure. And also the progression-free survival, you look up, that's also remarkable. And all of these were because they were objective response rates, which were markedly different, with 4.5 achieving a complete response in a stage 4, as well as 42% having a partial response. And the duration of response was nearly 5 times as compared to the chemotherapy, 6.3 versus 29.1. You could see those waterfall plots. That's a marvelous piece to look at, and as well as the treatment duration and time to response. Adverse effects do occur, but all of them being manageable. And we could see with longer follow-up, also with 35 cycles, there were no safety signals that were identified. The second study which was important was the nivolumab study, which compared the chemotherapy with the first line in Checkmate 26. And you could see that that wasn't much of a significance. Dr. Ullas Batra sir talked about this study in a varied of the forms, ATZ versus the chemotherapy. And you could see a good OS of 13 months versus 20 months with arm B, and subsequently overall survival in. So we have now known that PDL1 is a very good biomarker across the trials. You could see from in the meta-analysis around 6,000 of these patients, all showing that there is a correlation between the benefit of the immunotherapy and the results of it. And we could use these markers of the IHC interchangeably, the 22C3, the 28.8, the SP263. However, the SP142 has a lower sensitivity, which we know. And we know that immuno checkpoint inhibitors, they have shown the survival benefit based on the crossovers if they were there. So the CheckMate 26 allowed the crossover, which was around 60%. So there was a negative in that. While when we didn't allow the crossover, the pembrolizumab one, the Keynote 42, you could see a positive OS with them. Again, Keynote 24, where the crossover was 65%, it was still seen that the responses were durable and effective. All these shows that at least in first line situation, we can say safely bye-bye to chemotherapy, because you look at these curves, the Keynote 24, the Keynote 42, and the Empower 110, you carefully select a population of PDL1 more than 50% or a TC3, IC3 population, depending upon the clone of IHC you are using. And you could say in 1/3 of the population, bye-bye to chemotherapies. And is there a relevance of how deep the PDL1 positivity is with the responses and the PFS and the OS? You could see from this publication that the deeper the responses and the longer and the durable are the progression-free survivals, it's because of the increase in the PDL1. So if the TPS is more than 50 to 89% and TPS is more than 90 to 100%, the more durable are the responses. The second is the chemo-immuno combinations. We know that the chemotherapy induces an antigenic flare in our body, and IOs tend to capitalize on that. And that was the Keynote 189 study design, which took the all comers, even the PDL1 less than, the TPS less than 1%. And you could see it could demonstrate again those beautiful curves of 49.4 versus 69.2. And across the TPS also, you could see the hazard ratio of 0.59, 0.55, and 0.42, and the OS benefit also with the same. So it was similarly demonstrated in the Empower 150 study, the ABCP group, where the ABCP group outperformed the BCP group by a hazard ratio of 0.78. In the non-squamous population also, the survival was 18.1 months. And even though there was a crossover in the Keynote 21G trial, even after the crossover also, there was a remarkable OS and the PFS benefit, which led to the FDA approval on 10th May 2017. So we have two trials demonstrating a positive OS and the PFS of pembrolizumab. With Empower 132, there is positive PFS, but not OS. With Empower 150, there is positive PFS and OS. And with Empower 130 also, there is positive PFS and OS. All these showing that the chemo-immuno combinations have their respective approvals, even in the Empower 150 getting an EMA approval on EGFR and ALK population. So this is the hazard ratio across the trials, demonstrating a positive OS across the combinations of this. And similarly is the chemo combinations in squamous carcinoma. This was the trial which was latest in the armamentarium. Tasuki.
With us, just to say your time is getting up.
Perfect, ma'am. So it also demonstrated that if we replace the ABCP-A with nivolumab, you have the positive PFS and positive, not the positive OS. The reason wasn't known to it, but still it is remaining the same. But at the same time, you could look at the adverse events, the grade 3 adverse events, which were markedly elevated with chemo combinations. The last I would go to the IO combinations. The IO combinations, as we could see, that they were extrapolated from the melanoma trials, which demonstrated a beautiful, but that was the
Sorry,
ASCO
Vikas, could I
presentation.
ask you to just, could you
Wind up.
summarize your last
Perfect,
slide,
sir.
please? Yeah. Last slide, just tell me your summary. And,
Yeah.
and we should come up.
In future, what we will be going to would be the Pioneer one, where we could see, we could demonstrate a subset of population based on the PD-L1 density, PD-L1 cytotoxic T cell, CD3, CD8 ratios, and we could tailor the immunotherapy to every person of our population. Thus, we could say that in first line, Pembro is the undoubtful choice if it is PD-L1 strong, Pembro plus chemo in others, including the PD-L1 negative. ABCP has its definitive benefit in defined subgroups, and IO-IO combinations clearly doesn't place a good therapeutic strategy. The predictive role of TMB is uncertain, and we have a challenge of new combinations, biomarkers, and the duration. And I would like to give to the organizers. Thank you for the opportunity. And
thank you for that, because really very well put. Can I hand it over back to the chairs to invite Dr. Sevanti? Dr. Shyam Agarwal?
I think Dr. Shyam Agarwal is not there. Dr. Bapna is there? So I'll invite Dr. Sevanti if you are around, so that we can have the next session, please.
Dr. Nitesh, Dr. Sevanti is not in the group. So can we?
She was, I think she just dropped off again. Sonali, okay, there she is. Yes.
Yeah, she's there. She's there. Okay. Dr. Sevanti, you can switch on your, you can start screen sharing and switch on your mic, please.
Yes, Sevanti.
Nitesh, I still am having issues, I think.
This is working, Sevanti. We can hear you very clearly. We can see your screen. You just need to put your presentation on.
Okay, all right.
Yes,
So
this works.
okay, first of all, thank you for inviting me. And I'm going to do this presentation with a difference. Just because I wanted to keep it that way. You've heard a lot of data. And so Nitesh asked me to speak on cost limitations. I'm just going to present my perspective. So I work at Koplav and Dhirubhai Ambani Hospital. Cost limitations are few. Before that at Columbia, before that at Dana-Farber, before that at Albert Einstein, before that at Sloan. And here I bring the cost implications. So one of the things that we saw, and very nice, my slide is not showing, is that the lung cancer costs are one of the highest costs. And I just had a BMJ presentation wherein the largest cost that we see was in lung cancer targeted therapy. When you really look at all the different targeted therapies in the world for different malignancies, lung cancer targeted therapies cost the maximum. When we talk about driver mutation positive lung cancer, we cover a whole host of driver mutations. And the first thought that should come to a clinician's mind when you see a patient, especially in the clinic, is whether this patient is going to be able to be covered by the first line options that we have. And most of the first line options, as we all know, are extremely expensive. When we talk about osimertinib, alectinib, dabrafenib, trametinib, lorlatinib, any one of these that are being sold in the market, we know are above lakhs of rupees. So can the patient pay? Does the insurance pay? If it's not available in India, do we import? Are there clinical trials? Is there a compassionate access program? And what happens when there's none of the above? So one of these, I was just preparing for this talk, and I went back to data that comes out of 2000, early 2000s, then late 2000, 2015, 2019, 2020. So how does the payer arrange for payment for cancer treatment? And one of the things that I saw again was when you look at lung cancer, the therapy is one of the most expensive treatments. You look at the payer, how much do you need to pay to be able to cover your insurance costs? And the insurance costs for a normal payer, when we don't talk about these esoteric luxury medications, I call them luxury medications mainly because these are so expensive that if I were paying for it, I would think twice. But when you talk about the routine coverage, even the routine coverage is extremely expensive. And out of the circles that we see here and the kind of average claims for different cancers, the highest claim comes in for lung cancer. Today, we have so many options for lung cancer. And that just means that you have to get out there and try to treat. The patient has to get out there and try to cover. The family has to get out there and make arrangements for their loved ones. But how do they do that when the costs are so high? That's where comes in the information that there was 2019 when DPCO slashed prices. And especially when we talk about driver mutation positive lung cancer, the driver mutation that comes out on the top, the driver mutation that is the king is EGFR. And you have several generics, you have several biosimilars now to be able to cover the cost. And after DPCO, the costs have definitely slashed. There is some hope for cost limitations and to cover our patients with these drugs. Is biosimilar the answer? When you look at the development, so one of the things that I was really not aware of, and one of the questions that was asked to me when I was interviewing with TMH from New York, what do you think about biosimilars? And I said, yes, because I couldn't really understand at that time what implication did biosimilars have in India. And fast forward to now, when you need to remember each vial prices of the biosimilars. Why? Because they are relevant. They have really flooded the market. And one of the drugs that I don't have in the trastuzumab bracket is the trastuzumab from Intas, which we all have figured out. And so similarly, now we have several lung cancer drugs available as generics and biosimilars. And really, a clinician has to be savvy enough to figure out all these drugs no matter where you practice, because of what kind of clientele will enter next into the room, where you need to be aware in the interest of the patient as to how to get them the drug. And if it is the generic and the biosimilar, so be it. The idea is to cater the right kind of therapy for your patient. So definitely go to biosimilars. Next to me is clinical trials. A lot of these novel drugs are available as a part of clinical trial. So we have the WhatsApp group. I almost put it there. And then we have the CTRI website and of course, Google. Google Baba is ever friendly, and we can certainly search which trial, which drug available for our patients as a form of clinical trial. But at the same time, the challenges for clinical trials are known. A lot of our patients don't meet the criteria and fall out of inclusion-exclusion criteria of clinical trials. Having said that, when I run these multiple trials and I have space empty, trials not enrolling, my heart breaks because I just can't believe that every patient has the capmatinibs and the selpercatinibs in the world. Every patient has the pembrolizumab and durvalumabs in the world. So We have to step up as clinicians and really look out for clinical trial availability and guide our patients to the right kind of therapy wherever available. Now to touch upon the meat of the matter, which is specific targets. I think all of us are aware of this, and that's why the digression. So we know of the Archer study, we know of the Flora study, we know of the Tata data. I'm sorry, the slide has not come out fine, wherein we look at chemo plus gefitinib. And we have the data today in the interest of cost also, not just the survival. We have to be aware that we have just moved away from single agent first generation TKI, typically, specifically in mind with this data from Tata Memorial Hospital. And we have this second generation with afatinib, where we know that there is a provision to move on to the second line therapy. If at all the patient were to develop resistant mutation in the form of T790M, you keep the third generation for the next line. And we saw the GeoTag study enhancing survival in this situation, wherein you can really move the second generation up. So what are the finalities for cost saving in the treatment strategies? You know, you could do the first generation first line only for patients who can afford it. But most of us, third generation first line for the patients who can afford it. But most of us who are not able to do that would then think of first generation plus chemotherapy with the current data, or the second generation if the patient can afford that. And with the current market where you have the generics and the biosimilars, literally this is something that has become very doable, where you could implement a second generation or you could implement a first generation with chemotherapy very easily for your patients, where the patient cannot tolerate and cannot afford a second generation, even cannot tolerate more than a first generation. You would then go ahead and give a first generation. Then it brings me to other cost-centric specific target solutions for adenocarcinoma driver mutation positive. For ALK, crizotinib stands out, ROS1, crizotinib, MET crizotinib, HER2, afatinib, trastuzumab. And for the rest, again, it falls in one bracket. I may have left out a few, where it is chemotherapy, and if the patient has high disease burden, you may think of adding a BEV. But honestly, one has to really look out for alternate solution. And here's a few that I will show you. So this is ALK inhibition response from crizotinib to a patient who couldn't afford the third generation. And then there is progression. And then there is compassionate use of lorlatinib, patients still alive on lorlatinib 2 years down. And this is on compassionate program. So really reaching out and looking out for what else is available. Is a trial available? Is a biosimilar, or a compassionate use of the drug? This is a ROS1. Crizotinib failure, lorlatinib, and the picture is out there for you to see. It's a massive disease in the chest, and all of the disease melted with lorlatinib, and a magical response prevents the patient from intubation. This is a patient on BRAF/MEK inhibition clinical trial. This is not a clinical trial here. Transparency. This is a trial from my previous patient, and significant response from BRAF/MEK inhibition for this patient. Elderly patient, could not do chemotherapy, found out to have BRAF mutation positive, and was offered BRAF/MEK. I had to drop the MEK as a part of the clinical trial, and just on BRAF inhibition, excellent response. Capmatinib for a MET amplified patient, again, elderly patient, couldn't do chemotherapy. On the sequencing was found to be MET amplified, an excellent response to capmatinib in this setting on compassionate access program. So the writing on the wall is we have to know our patients, we have to know our circumstances. The succinct message that I really wish to deliver is we have to understand the patient's pocket, and the rest is all jugaad. And the Jugaad includes insurance. It includes biosimilars, generics, clinical trials, compassionate programs. And really, you have to get out there to figure it out for your patient. You have to be aware, you have to be savvy, and you have to fold your sleeves and ask, what can you bring for your patient in these settings? So I hope I've kept it short and sweet and delivered the message that I had to. I decided to not bore you with the data. Thank you. And
Thank you very much.
thank you, Nitesh, for having me. This is a very, it's a great meeting that you're doing. Thank you.
Thank you. Over to the chairperson, please.
So thank you, Dr. Sevanti. That was really very thought-provoking talk on cost thoughts. So without much delay, I will invite our next speaker, Dr. Prabhat Malik. He is going to speak on small cell lung cancer. And again, cost and immunotherapy.
Dr. Prabhat, you can start screen sharing, please. Yes, we can see you well. Are you muted? Are you muted? Dr. Prabhat, we can't hear you. No, Dr. Prabhat, we can't still hear you.
Am I audible here?
Yes, you are audible now.
Yes.
So I would use different.
Yes, we can see you are on 2 devices. That's okay. That's all right.
So actually, I'm using a different.
Yes, that's what Jugaad, Dr. Sevanti was talking about.
Yeah. So just give me a moment.
Yes. So Nitesh, you want to answer that question? Dr. Daniel Chan has put in the chat, and Dr. Meenu can also take that question. Oh yeah, Dr. Sevanti can take it. Yes.
Sevanti, could you take that question? Dr. Chan wants to know what all compassionate programs are available in India at the moment. Okay, I think while Sevanti's audio might be a problem, Daniel, we have
I'm taking the
many
question.
of these.
I'm just answering.
Sorry, please. Yeah.
So basically we have for today, we have for ALK, we have for ROS, we have for NTUC, we have for, we finished our compassionate access for BRAF MEC, but we have ALK in clinical trial, I misspoke, ROS1 in clinical trial, we have MET in clinical trial as well, and we have I think that's where it finishes. We don't have, so we have trials for HER2. We have trials for, we don't have trials for BRAF MEC. We don't have trials for exon 20. And we don't have compassionate access for exon 20 as well. But for ALK, ROS, MET, and HER2, we have trials ongoing. At this current time, we don't have a compassionate access for these. We have for ALK only. And NTUC. NTUC, we have a compassionate access.
Yeah.
Okay, Dr. Prabhat, the stage is yours, please.
Yeah, thank you, Nitesh, and thank you for inviting me here. So in next couple of minutes, basically the job assigned to me is to talk about small cell lung cancer and the role of immunotherapy, the cost implications, and how to choose the patient, whom to give and when to give. Well, as we all know that small cell is one of the most aggressive form of lung cancer, and it constitutes around 10 to 15% of all lung cancer. And before maybe this year, it used to constitute less than 5% of the talks on any lung cancer dedicated conference. We used to hardly discuss or listen about lung cancer, but after the introduction of checkpoint inhibitors and some development in terms of therapeutic armamentarium, which we have for the treatment of these patients, so nothing has really changed over the last 20, almost 15 to 20 years before this year and last year, when we have some hope for these patients and something interesting to discuss about. Majority patients, they present with extensive disease. It's a very platinum sensitive disease, but unfortunately, most of the responses are short-lived. This is mostly for postgraduates. In terms of biology, this small cell lung cancer, unlike non-small cell lung cancer, is characterized by the loss of tumor suppressor gene. On the other hand, for non-small cell lung cancer, it's more of alteration in the oncogenes, which you can target by therapeutic strategy. So this is the reason why we couldn't have much of targeted drugs working in small cell lung cancer. Small cell lung cancer arise from neuroendocrine cells, which are present in the bronchial epithelial line. And how these, the airway cells actually differentiate into a small cell histology is governed by these two pathways, Notch pathway and ASCL1. So if you have a lung progenitor cell, the upregulation of ASCL1 guided towards a neuroendocrine fate. On the other side is the Notch pathway, which basically regulate the ASCL1 expression. And if the Notch is functioning, it would lead the progenitor cell to transform into a mature type of epithelial cell. But what actually happened through continuous exposure to tobacco smoke, it leads to inhibition of Notch, which eventually leads to upregulation of ASCL1 and make family of proteins. Side by side, if you have a P53 and RB loss, the lung cells eventually transform into small cell lung cancer, and that's how a small cell lung cancer develops. We have seen various molecular classification of non-small cell lung cancer, but we, as a clinician, we do understand that small cell lung cancer, all small cell lung cancer doesn't behave in a similar way. People have been struggling to classify them into various subtypes, and now there is a proposed classification that based on the molecular features, they can also be classified into 4 subtypes, and now these types are for the postgraduate, they can just remember it by A, N, Y, and P. So A stands for ASCL1 overexpression, and for NeuroD1, YAP, Y for YAP1, and P for POU2F3. So these are the specific proteins which are expressed. So most common subtype is small cell lung cancer type A. Coming to the therapeutic strategy, conventionally, small cell lung cancer, as we all know, we have been treating it as a limited stage disease or extensive stage disease. Limited stage disease was treated with concurrent chemoradiation, and if they have a good response, they are treated with prophylactic cranial irradiation followed by surveillance. Extensive stage disease have been classically treated with systemic treatment. So far, we have been treating these patients with platinum etoposide combination or a platinum irinotecan-based combination. The role of PCI and thoracic radiation have been a little controversial in this group of patients, and when they progress, they are treated with second-line therapy. Small cell lung cancer, if you see, if you put all the tumor types across, and small cell lung cancer generally lie on the right side where you have high tumor mutation burden. Like other lung cancer subtypes, small cell lung cancer also have reasonably high tumor mutation burden, which actually highlights the role of checkpoint inhibitor use in these group of patients. This is just a brief overview of the key studies of use of immune checkpoint inhibitor in small cell lung cancer. Particularly to highlight are these 4 studies which are shown in the first row, all phase 3, 3 phase 3 and 1 phase 2 randomized trial using combination of chemotherapy along with an immune checkpoint inhibitor, particularly in the first line of therapy. And all these 4 studies have come up in last 1 or 2 years and have actually changed the treatment paradigm of small cell lung cancer after such a long time. Just to discuss a few important studies, the first one was the IMpower 133, where atezolizumab was combined with chemotherapy for extensive stage small cell lung cancer. Atezolizumab with platinum etoposide versus platinum etoposide alone, and this trial showed a modest improvement in progression-free survival, but a statistically significant improvement in overall survival. The magnitude of benefit was modest. It was around 24% reduction in hazard of death when the atezolizumab was combined with chemotherapy. The combination was well tolerable as expected. Apart from immune-related adverse event, other side effects were comparable. And after that, another study, they called Caspian study, where durvalumab was combined with chemotherapy. This study actually had 3 arms. One arm had 2 immune checkpoint inhibitor along with chemotherapy. That's a 4-drug combination versus a 3-drug combination versus chemotherapy. Initial analysis showed that addition of durvalumab to platinum backbone chemotherapy leads to improvement in overall survival. And again, the magnitude of benefit is almost same what we got with atezolizumab when it was added to chemotherapy. And if you see that adding another immune checkpoint inhibitor to this combination doesn't really help, and there's no further improvement in outcome. It simply adds to toxicity and the cost. Again, it was a well-tolerated combination. I'm not discussing all 4 trials here, but we can see if you put all these trials together and see the composite effect in terms of improvement in overall survival and overall in progression-free survival, which seems to be comparable. All the trials leads to the gain of hazard ratio is almost similar, somewhere like 24 to 25%. And the overall survival and progression-free survival seems to be comparable across all these 4 trials. So based on these study, we can actually say that addition of checkpoint inhibitor to platinum etoposide combination significantly improves survival. There's no doubt about it. 2 drugs, atezolizumab and durvalumab, are already FDA approved. And positive results of nivolumab and pembrolizumab studies are also corroborating with the same finding. The combinations are safe. And so we can actually say in 2020, the checkpoint inhibition along with the chemotherapy is probably the new standard of care. But the big question is still remain unanswered. That is, do we really have a good biomarker? Can we really select the patients who would respond to really benefit with checkpoint inhibitors? Because we know that the impact when we add it to chemotherapy is modest. But is it the modest impact on an overall population, or is the big impact on a small subset? That question still remain unanswered. So people have tried to interrogate into 2 possibilities: whether PD-L1 expression on the tissue can really help us, or is the tissue or blood-based tumor mutation burden estimation can help us. So the initial phase 2 trial called Checkmate 3-2, which evaluated nivolumab alone or nivo-ipi combination in previously treated small cell lung cancer, where they found that PD-L1 expression doesn't really predict for the response rate. And another exploratory analysis of the same cohort of patients where they evaluated the tumor mutation burden. So they found that high TMB seems to be differentiating these patients. People with high TMB had significantly better overall survival, response rate, and PFS. But unfortunately, the IMpower 133, the chemo atezolizumab combination, did not replicated the same results, where high blood-based TMB could not differentiate responders versus not responders. Keynote 158, which was the use of pembrolizumab monotherapy in previously treated patients, found that if you calculate the PD-L1 CPS, which is a combined score of PD-L1 expression on tumor cells and immune cells, you can differentiate the patients who benefit versus who don't benefit. but the subsequent phase 3 trial, Keynote 604, failed to replicate the same results. Whether it's the effect of, because in the previous trial, it was a pembrolizumab monotherapy. Here, it was a combination of chemoimmunotherapy, whether combining it with chemo actually negate the effect of PD-L1, that we really don't know, but it looks the same. In Caspian and IMpower 133 also failed to demonstrate any impact of PD-L1, be it immune cell score or a TC score or a tumor expression of PD-L1. Irrespective of the cutoff level, it did not really differentiate between the responders versus non-responders. And the same was the story for blood-based TMB, as I discussed earlier. Maybe in future, when we now, because since we have this understanding that the small cell lung cancer have various molecular subtypes, and there are some data that like YAP1 subset of small cell has more of inflamed T cell gene signature. Possibly these are the group of patients which may benefit more, but these are certain things which are still to be answered. The next question is, which is a quite tough one, whether these strategies are cost effective or not. Honestly speaking, we don't have too much of data on a formal cost-effective analysis. I found this one interesting study which did a modeling, a Markov model cost-effective analysis for IMpower 133. And the authors concluded that this combination of atezolizumab platinum etoposide is not cost-effective in American perspective. So obviously we don't have any Indian analysis done for these kind of study. And if you look carefully, the benefit of adding atezolizumab over chemotherapy was increased the cost up to $52,800 US as compared to chemotherapy alone. And the gain of QALY was only 0.1. So you can imagine the impact in terms of cost effectiveness is really minimal. So my take on the role of immunotherapy in small cell lung cancer is that no one can deny that this combination in extensive stage small cell is a new standard of care. But if you ask me, the magnitude of benefit is really modest. Cost effectiveness, at least the formal analysis showed it's not cost effective in American perspective. And it's common sense says that possibly not effective in Indian perspective as well. The next question which Nitesh wanted me to answer, that how to choose our patient, whom to give this combination or use immunotherapy, and when to use. The answer to the first question at whom, for whom we should use, honestly, I don't have any answer to that because we don't have any good predictive biomarker. As far as the data is concerned, that it's to be used for all extensive stage small cell lung cancer, but along with chemotherapy. If you ask me when to use, the answer would be the best time to use is first line chemotherapy because you have maximum data in this setting. That in first line you have the whatever survival benefit you have in first line, and possibly using it with chemotherapy makes sense. Thank you.
Thank you. Thank you for answering my question, Prabhat. Over to the chairs. Dr. Shyam Agrawal, are you there, sir?
Dr. Bapna was also there, I guess.
Dr. Bapna?
Nitesh, we have only Dr. Meenu ma'am here.
Okay, I think there is some problem with signals dropping. If they are not there, Dr. Meenu Walia, can I hand over to you, please?
So thank you, Dr. Prabhat. That was indeed very specific and to the point. And I guess as everybody pointed out, probably the right biomarker we are yet to find. Maybe there is another biomarker which we don't know that works in small cell lung cancer, which we do not know at present, and maybe in coming times there will be something else. So let us see what the future has, and maybe the more trials in the near time will tell us what next to use. And without wasting much time, I think I'll hand over back to the organizers, Dr. Nitesh, Dr. Shubha. Let's go for
Thank you very much, ma'am. And Prabhat, really a heartfelt thanks. There was no one better to talk about this. You have not emoted as much as you personally believe in this, but nevertheless, I think that's a very good balance. Thank you.
Yeah, thank you, Nitesh. Thank you for that.
Thank you very much. Okay, I'll hand over now to, I think, what is an extremely important topic. It's something which is very close to our heart and often does not get covered in most conferences. So everybody who's there right now, I want you to please stick around for 30 more minutes. This is very critical. It's about advocacy. It's about support. It's about cost also. It is about this gentleman who single-handedly, for his wife's ALK positive case, has fought the world and in fact taught most of people like myself of how to use the system to the best advantage. And so please hear this story and see how a patient's and a patient's family can make us better doctors. I hand over to Vivek Tomar, a friend. Sometimes I feel a guide, but certainly a friend. And I think he will speak about survivorship and survivor in lung cancer.
Hello, everyone. Can I check? Can you hear me okay?
We can hear you well. We can hear you well. Yes.
Okay. And before I go into the presenting mode, the most passionate thing of my life, just a disclaimer to the organizers that my wife, my love Kusum, who used to be my partner in crime for patient advocacy for last 7 years, and she's no longer with us, but she has joined without registration. So bear with this. So I can't left her anywhere. Okay. So I am trying to share my screen.
Vivek, as an organizing secretary, I allow Kusum to join.
Thank you, sir. Just let me know when you can see my slides, please.
You can see them. You can see them.
Okay. So the topic is which is the end product, that is survivorship for lung cancer. Myself, Vivek Tomar, I am a patient advocate for lung cancer, cancer research, clinical trials, and timely access to the latest treatment in India. A caregiver, a proud caregiver, works with many patient support group, co-founder of ALK Positive India, and in advisory role to government, NGOs, and pharma companies, works majorly under the name of Rise to Survive Cancer. So let's start. I want to say thank you, and this is not just a thank you for the invitation. This is a bigger thank you, much bigger thank you, because as Dr. Nitesh rightly mentioned, how many times we hear true patient voice, we hear patient advocate, especially in medical conference or any conference. How many times you see that patient advocate, your patient's voice is the initial of the program. They are at the last when most of the policy maker or key decision maker already left. And it is very important that we kept patient advocate in such critical platforms, including the medical one, because it humanized the cancer, it humanized the problem. And I just give you the example, if you can see the photo. So this was when we went to meet with the Health Secretary of Government of India, DCGI, and their whole team. And there were some leading oncologists and all pharma companies, leading pharma companies representative, and they were talking clinical trials rules, business, and everything. When Kusum and I spoke, everything changed. And they were listening, they were seeing that, okay, we are talking about Kusum. And I'm so proud to say that that day we made 3 proposals. One was that if there is medicine already approved in other countries, why a clinical trial required in India? Why there is a limitation of a PI, that how many trials they can have, because we have a less number of PI in India, and the bed limitation, which was minimum. And you know, all 3 were accepted within 1 year by Government of India and the regulatory office. So my message is, and that's my first message, is that power of the patient voice cannot be underscored. If we too can do, look what all patient advocates with oncologists, surgeons, policy maker can change for this India. And that's how I'd like to start. And thank you for this milestone NALCON team because first time there is a keynote speaker as a patient advocate. So thank you so much. So let's humanize first. I'm going to give you a quick flashback of our journey only in 5 minutes, and some key points, and I'm trying to connect those key points which I'm going to convey. So this is my journey. This is our journey. This is journey of love. The left-hand side photo is just before diagnosis, and the top right side photo is 10 days before Kusum passed away, and in between it was just fighting with the cancer. Kusum was diagnosed in early 2012 at stage 4 lung cancer, metastatic to brain, and n number of parts in the body. But I will take 2 years back. She was earlier diagnosed with migraine for almost 2 years by neurologist. And please mind, I would be trying to be very open and honest with all big due respect to everyone. So this is nothing to say wrong to anyone, but this is a true story. Then then continue the problem increase. We went to one of the NCR big hospital, a topmost neurologist, and he diagnosed her with TB, first with brain tuberculoma. And after 6 months of treatment, at that time there were 6 nodules. And after 6 months of treatment in early 2012, we came to know that, oh, there is a cancer in his brain. Oh, there is a lung cancer, which is already metastatic to brain, and now mets are 10, and some are in centimeters, and 2 were in the inches. That's how our journey starts. So the world first we start with the tuberculosis wrong diagnosis, which usually very much happened in the lung cancer area. Then we were asked how much time she do have, because that was the most important question for us. Just to mention that Kusum and I both were pharma background. We were pharmaceutical scientists, and at the time of diagnosis, Kusum was associate professor in a pharmaceutical university. When we asked, we were given 3 months to 6 months to live, and that was the original data at that time. And it happened true, because after 3 months of chemotherapy, and even at that time, crizotinib was not there. She went into coma with severe pericardial effusion and all over the body. Luckily, in the same month, US got approval for crizotinib. It was not even available in compassionate ground in India. We worked, and within a week, we got crizotinib. It worked well for almost 2 years. Then, despite brain mets, then we got progression. We thought, okay, we will get medicine again. So what's the new medicine? So it was Novartis Ceritinib. And I thought, okay, let's connect with our oncologist and let's get Ceritinib. Was it approved? No, but within few days, luckily again, it got accelerated approval in US, first approval. So then we were looking for the clinical trials were going on all over the world. We met and we found that it cannot become in India because something bad happened between 2012 to 2014 in the clinical trial one in India. Some people did wrong, and then everyone become guinea pig. Then every principal investigator become a butcher, and every pharma companies were money, and the loss were majorly the patients like us. Kusum was without any medicine, and it was 2 months, and she was almost going to die, and she was almost declared died at that time. And then we fight. I took leaves for a few months from my job, and we fight. I know maybe the people from Novartis or policymaker or some of the oncologists here, I fight with you all. Then you became my good friend. I remember it was a medical conference, SARC Oncology conference in Gurgaon. And we obviously, as patients, we were not in there, but we took some pass, we took some jugaad as mentioned, and we entered. And Ravi Shankar, Sri Ravi Shankar was there to do meditation for oncologists, and he usually asked questions. And Kusum asked one question. She woke up, what is my mistake? Because I'm an Indian, I can't get the medicine. And things changed. And after 3 months of struggle, we bring clinical trial of Ceritinib in India, and Kusum became the first patient to get that medicine on 1st January 2015. the journey continues. Again, Serotinib works wonder. It again went to almost 2 years. Then this thing came resistance, and this time it was in brain. The numbers started to grow. 10 mares, 12, 13, 15, 16, 18, 20, 21, 22, 30, 32, and the bigger one. We asked for medicine. Now the next one was Rose Alectinib, and I know Rose people are here and they would be smiling. We came to know that Alectinib is not planned for India at all, because it was blockbuster, and India, because of the people started to create generics, so they have not planned for bring Alectinib in India. Meanwhile, it goes around 3 to 4 months, and Kusum went into paralysis. At that time, I was crying, and I was very angry. And I started to fight with and work with. I am doing emails on, even for the thing on the emails where you mentioned like contact us, and we found support. Then be it NDTV, Barkadat, G News, and many of you who are in the call as oncologists and pharma companies support us. And I it's a huge long list, and it became a campaign. And we reached to the Roche global level, headquarter level, and they changed the rule for India, for Kusum. And she became the first patient from India to get the Alectinib under compassionate research program on 17th January 2017. And after that, Kusum asked me, what about others? Because there were 17 other patients in the clinical trial of Serotinib who already progressed. And we continue to work, and the policy changed for all the patients for India. And now you see lots of patients are on Alectinib and Serotinib. The drug wonders, it was 17 January 2017. And in September 2017, she completed 5 years at stage 4 lung cancer metastatic to brain, bone, adnexia, ovaries, and backbone and everywhere. And she ran marathon in Delhi. And this middle photo is there, where she ran in this marathon in 2017 after 7 or 8 months of paralysis, with a t-shirt that 5 year stage 4, serving with hope, courage, clinical trials, and research medicine. And for me, it was the love. In total, Kusum participated in 6 research medicines and clinical trials. And unfortunately, she passed away on 5th Feb 2019. And it was not the cancer. Some of you know, means cancer was under control. She was again on a research medicine, but her body was not that good internally. She has struggled a lot without medicines when searching for these new medicine. But before she left, every L medicine is now in India, and I'm so proud of her, and I want to thank you. So this is my journey, and I want to now move further and connect. This just few photos and how we live the journey. This was Kusum at different phases, and a smiling face, never wear a wig, because she said cancer is not my thing. The most important thing, she was never a smoker, and that I would like to cover how we struggled as being stigmatized after having lung cancer. And we celebrated every year cancer anniversary on the day we were diagnosed until she passed away, because we enjoyed the life every moment despite the struggle. So this was our journey. Sorry. Now I connected the point that she was a never smoker, but there is a stigma, and I want to challenge this audience today that we are not doing right, even in India. When we talk about the lung cancer advocacy, we talk, and we did recently also, about smoking and everything, because that was easy to target. But you know how patients go to treat. You can't imagine the troll Kusum and I got when we started the advocacy for lung cancer or clinical trial. For clinical trial, we were said guinea pig, but for lung cancer, we got so much abuse in the name of, no, she must have smoked. And I said, no, because we were doing advocacy. There are a lot of articles, videos on media. So someone said, you are lying, she must have smoked because it is a lung cancer, or her parents had smoked, or you must have smoked. No, we all never did smoking. But unfortunately, we never speak. When we speak of lung cancer, we speak of only smoking. We know that lung cancer is turning into epidemic in India, killing more people than colorectal prostate, and I'm sure this already covered. As per Lancet report, we know if 43% is from the tobacco, so around 43% is also due to, could be the air pollution. And I know, I see Kumar Parbar, Dr. Prabhat Malik, and all of you, lot of studies, Dr. Lars, showing the incidence of lung cancer cases are alarmingly increased in non-smokers and women in India. And we have data now, as per IRC report, increase in much more dramatic in women in India. And have you ever thought why only pink light for breast cancer awareness? Why nothing has happened in the lung cancer awareness month in India? This is the photo for this month, which I took from the Hyderabad when everything is pink. I want to take a long pause, though there is no time, but think about it, because we all are guilty. We know that there are now majority of the new lung cancer cases are never smoker or non-smokers, but we don't talk about it because it's hard to talk. But if we as leaders in our areas, we who passionately are sitting today, we are not going to change this, nobody is going to change this for us. So my takeaway message is anyone with lung, including you, me, and anyone can have lung cancer. And please, the other message is help. Please help us, help you to fight with this stigma. Let's help each other to light up the lung cancer in India so that at least people start to talk about it empathetically. People start not to abuse us. Someone asked me, and sitting in this group right now, 2 days back, why only Vivek is doing lung cancer advocacy, not others? Why there is no lung cancer patient advocate? Because first, we have such a poor survival rate in India for lung cancer. Nobody left, no patient left. Almost everybody is dying. And then second reason is we are getting abused. And not everybody can be abused, and it's not hard to getting those abused and proudly say that I will continue with the lung cancer advocacy. So please help each other. The next point, and I'm sure it covered in my previous presenter, wonderful presentation, the clinical trials. And I'm going to show you something, a quick video, and I hope if it can't change anything, I'm not sure what's going to change anything. So let me know, I hope you can hear this.
I want to say just few words on the clinical trial. Most of the well-educated people and media, they use a word guinea pig for the patient or for the human being. But I'm proud to be a guinea pig who can contribute for the society. If we can contribute to the society, then what we can do. I'm very proud of myself that I contribute for the patients who are not getting the medicines. This advanced technology, there is a heading there, research touching the life. No, research giving the life, not only touching the life.
I think that's the message. Research touching, not touching the life. Research is giving the life. Research is saving the lives. And these are the success stories from our L group. So Kusum was at that time the longest survivor. I hope now there may be more survivor in India with all medicine available. And she participated in 6th trial. And then my dear friend Linnea Olson, who is the longest L survivor, 15 years and counting, never smoker. She is now her 4th phase 1 trial of ELK treatment, already completed 3. First patient from crizotinib, first on ceritinib, first on lorlatinib, and now after lorlatinib failure, she's in her next with Dr. Alice Tissot. She's in the next 4th phase 1 trials, and she's still surviving. And it's for 15 years and counting. And these are the faces you want to see, we want to see, and world wants to see that how it's research saving the life. And there was a question always when I speak that patients don't ready for trials. No, patients want research. So this is the example from ELK group. On 23rd September, we give $1.6 million of research project, which we collected all over the world through donation, purely for these 3 projects, which I'm not going in detail. But my message is, we have not seen a single application from the India India researchers for this such a huge budget project. Also, when I try to speak with many, there were reasons given that the rules are not good in India, we can't do the clinical trial. And I always wonder, what about those in different hospitals who are doing clinical trials every year? Are not they afraid of those rules? And if there is any problem, let's work together and change this thing. So my takeaway message is to all you with hand folded, please, 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 you all start to participate, lead, or even try to have only one clinical trial per year at your site for lung cancer, and see how the accessibility of medicines, affordability of medicines, survival rate, and quality of life will be changed for lung cancer in India forever, because cancer research saves life. Moving to the next one, I'm sure it covered from the day one to till now, affordability and accessibility. The previous presenter has shared some really good data, and I'm sure others have given raw data. What I'm going to share a bit of the other perspective also. So this year, May 2020, as you know, we see 6 new lung cancer treatment approved by US FDA. So they are great news for lung cancer. Since 2015, 28 approvals, in which 21 approvals from only January 2018. And for so these are things, when everything is so good, then why, as per this EIU 2020 report in APEC, India is having one of the lowest 5-year survival rate in the lung cancer? Why patient in India not able to get latest best treatment? I did some surveys in the ALK patient community, and please note that these surveys are not published or IRB approved. So take it indicatively only, and because it may not provide the actual picture, but it will give you the idea. So ALK and global group. So if we see, we are still more on crizotinib and ceritinib, not on alectinib, brigatinib, or lorlatinib, and there may be the reasons. I have not shared the global survey data, which I do have, because it is currently under review and approval of IRB and may be published in the one of the global conference. But global ALK community, if I suggest that it has 80% patients on alectinib or lorlatinib combined. So it is completely filled. And when I try to find the region, just in the data form, so if you can see, 62% Indian ALK patient has compromised in selecting AKI, and I would say 62% Indian oncologist has to compromise in selecting the preferable ALK TKI, which could be alectinib, which could be lorlatinib, based on the because of the high cost of medicine. Targeted therapy cost biomarking testing. I was just thinking, could Ayushman Bharat, who have 5 lakh rupees, because there are hundreds of poor ALK patients who can't afford anything, could be answered. And in one of the program, I got the opportunity 2 months back to ask with CEO of Ayushman Bharat, Dr. Indu Bhushan, can targeted therapy be included in the Ayushman Bharat? Okay, answer was different, but my biggest worry was, his answer was, what is targeted therapy? And I was like, what? He is having so, I'm not taking about any company pharma medicine. I'm taking about targeted therapy, which is kindly present and a big future of the big present of the lung cancer treatment, and especially in the adenocarcinoma. But he was not aware. Who's going to make him aware? He may be able to help. It's you and I, but never. And same for biomarker testing. The cost around 35,000 to 50,000 minimum, and how much biomarking testing thing, and that I'm going to cover very soon. So this topic, and which I connect further, is timely diagnosis, right diagnosis, right treatment. So some of the, this slide was presented yesterday in ISLC liquid biopsy conference around the same time, and that's I copy paste because it just connected with my next slide, that first biomarking testing don't happen. If it happen only for EGFR, max ALK, but not for other mutations. And then 45% after biomarking testing, not given the right treatment. In many EGFR and ALK patient given immunotherapy as first line treatment after diagnosed with the right mutation. And you know it because I have raised it with examples on Twitter many times, that some of the doctors who may not be aware of the latest thing, who are the rural part of India, they don't know about what is the latest, but who's going to make them know? I think it's you, the leader. who was here in conference, not the person who is not in the conference. And I have a lot of data and actual example where such gaps were there. So this is an example about timely diagnosis. 80% of patients currently in India in my group of ALK diagnosis is only diagnosed at stage 4. So the question is, why not timely diagnosis? Why not we are having the test? Why not PMJ have something for lung cancer? Why not what we are doing? And then about wrong diagnosis, which happened in Kusum case. So 39 patient has the wrong diagnosis before actual diagnosis and treatment. And the last point, which I'm trying to connect, and it's again with whole due respect, that 45% of the patients in our community move to the metro cities with doctors like yourself, because they were not able to get the right treatment or better treatment, or their oncologist was not aware what should be given. And these are the facts from the patient community, and which we need to change. So what is takeaway? I think you all and this organization ISLC, as the leader in the field of lung cancer, can help and should help to ensure that best treatment practice for lung cancer across pan India should be practiced. The next one is about the quickly patient advocacy. So what is advocacy to change what is into what should be? Or in my own words, patient support groups are giving the Baisakis because to support either money support or emotional support, while patient advocacy is giving the enough food and the right treatment so that they don't need the Baisakhi. And this is the different. And unfortunately, in India, we have lots of patient support group, but where are patient advocacy? I'm just giving you an example, not to showcase myself, but Kusum and I, when we started this patient advocacy, and you see, we are here we did for clinical trials. Even we have now Brigatinib, Alectinib, Pijotinib, all medicine in India, and with Kusum. Even when Kusum left, Suryans and I, with lung cancer treatment, we run in the marathons for the compassionate program. There were in hospitals and outside, there were people looting. They are charging for import license, and we did how to get the license, and it's on YouTube and for motivation. So the point is, patient advocacy is the partner, and they can help to get it, what needs to be avoided. And I think we should learn from ISLC. So when I went to the World Lung Cancer Conference to receive the Best Patient Advocacy Award, I was shocked, and I'm still shocked, and in a good way. The patient advocate was center, and the physician, and it was such a big conference. From the keynote, from the every press conference, from every key decision, patient and were engaged, empowered, and like the ALK data I've shared, that patients were collecting money and giving to the doctors to do the research, to the researchers. Can not ISLC and we and the all other medical community and all the patient community and the government learn from this and involve more patient advocate and make them as a true partner to help you, because it will reduce the burden to every one of us. The next quick one is about the which I want to raise, and I don't know why it has happened, Global Lung Cancer Patient Support Group. So there are we talk about, and you talk about, I follow Twitter, I follow research paper of yours about global oncology, and lots of paper are on global oncology. And you know why global oncology is important. You are already doing national oncology through this conference. But when it comes to the patient support group, there are still the old mentality that patient support group should be hospital based, not the national level or international level. And there is not a single patient support group dedicated to lung cancer in India except mine, that is ALK positive, a sister form of ALK positive global group, which Kusum and I created. But you can go into slide later. We have now groups who are supporting, and they are across the world. We have patient support group. The other example, which I think Dr. Kumar Prabhas has mentioned, about TMH online lung cancer support group. So Dr. Kumar, Dr. Vanita, I, Prabhat, Sanjeev, we sat 2 years back and we thought of it. So TMH was doing again the hospital thing, and I said, if you would make it hospital thing, it would remain the hospital one. patients from North India or from the Assam, Bihar, they may need the equal support. They may get the support from Kumar Prabhas and online. And then we generated this idea of online lung cancer, and now you see how it is going. And it always has a patient advocate, motivator speaker, and a doctor and a nutritionist or the emotional support group. Takeaway messages: involve patient advocates, please, at each and every platform. They are here to partner and help you to achieve the common goal of betterment of patients. They are here to take off some of your burden. They are here to help to achieve what is needed. And we are in this together. So towards the closing, and I would not say that this is summary, but again, I'm hand-folded today because this is a big opportunity. I would say this is a request to each of you, and especially the ISLC as an organization, that survivorship for lung cancer is a journey, is a shared journey. Okay, you want survivorship, we want survivorship, all of us want survivorship. So then it's a shared journey, and you are the one who could, being the leader, change the face of lung cancer. We will be together, but we need that support together. So obviously, let's no more stigma, please, no more stigma, and let's raise better awareness about lung cancer next month, when November is the Lung Cancer Awareness Month. Research saves life, and who could better say than Kusum what she did in that video. And as like my previous presenter, it is the big answer to the cancer problem, lung cancer problem in India. It is kind of the next level of treatment. So if ALK has first generation, second generation, third generation, this is like the fourth generation. This is like the another option, like radiotherapy, chemotherapy, target therapy, then clinical trial is another option. We have to look the clinical trial, and all of you and patients, we have to come forward and do more trials. Why only 1.4 global clinical trials in India, despite 17% population disease burden? Why not it is 32%? Let's make that, and it helps us. The next is encourage, engage and empower the patient advocates. And I can't say more than enough. Let's work with the policymaker, pharma companies for affordability and accessibility. If Kusum and I can change so much thing as one person. So we both were not decided that we should have lung cancer. We decided but to become a lung cancer patient advocate or clinical trial patient advocate. See what we as a team can do. And this is not a dream which can't be possible. This is just very near, and we have to do it. It is just in front of us. And like global and national oncology, let's be open for global and national patient support group. It would help you, because then patient would be more empowered, engaged and encouraged, not as self-advocate, and they come ready with the right questions, and they come ready with the options. They will understand, and you will have less time to make them understand. And for the pan-India, I think you can only do is right and timely diagnosis and treatment across pan-India, because you can help others to understand who don't reach to such conferences. And in the end, I look forward for ISLC and you to lead this, and together we can change the face on lung cancer. And remember, as Kusum said, in this case, losing is not an option. So thank you.
Thank you, Vivek. That was touching, but more importantly, I think it was enlightening. I think we all need to wake up to the voice that you're trying to raise. Can I request Dr. Harith to make some comments and
Sure, Nitesh.
say,
I think,
yes.
Yeah, I think Vivek closed on a very powerful note. Losing is not an option. Actually, I'm getting goosebumps as I'm repeating what he said. And that is the spirit with which we have to get into the game. There's no shortcut. There's no pessimism. There is no, this is what I can do and this is my limit. There's no such thing at all. This is just, we have to multiply our power, and losing is certainly not an option. And there's so much headspace. There's so much opportunity. We are not really realizing the power. I think what we brought out very clearly, that we are thinking at institution level, at team level, at individual level. The game is much, much, much bigger. It is about thousands and millions of lives. And we have to just stop thinking like that. Just put your hand wherever you can, do whatever you can. I think we have to join hands, create a much bigger platform, and the world is just waiting and begging for us to play our role. I think the game is very well set, and we are so fortunate to get Vivek into the game. I think Nitesh was the one who got this idea, and all of us really jumped on it. And I think these last 30 minutes have a very transformational effect on all those who have seen right now, participated, and all those who will see subsequently on YouTube. It will have an amazing effect. I'm sure he's gone and spoken all over the globe, but the experience and his journey itself is so inspiring. Getting involved, I think at this time when due to COVID, there's a lot of openness in the society regarding participation in trials, because they've realized that through trials that you are able to modify treatment, come to conclusions. This is the right time when in the oncology space, we have to really push hard amongst our people, get trials into our systems, into our institutions, work with the pharma companies with ideas and innovations, and create a model of maybe weekly or 2-weekly engagement program where we monitor how this is progressing, how we are moving forward. Only then probably make a difference. I'm so grateful that Vivek took time out for this, and very happy. Thank you so much.
Can I ask Vivek a question? Vivek, you said you're from a pharmaceutical background. So do you think that your being from a pharmaceutical background helped you to get around this thing and get a head start in getting the drugs for your, because not everybody can do that. Okay, we get so many patients, and even patients who are educated, but they can't do all this what you have done, and that is where we need leaders like you. But do you feel your having a head start in the pharmaceutical background helped you?
Okay, so it's a good question. I think it helped me when I was speaking with our oncologist, because we were able to make a really good talk and options, and that helped in the treatment. But when we were looking for clinical trial, it was every other like patient, it was to save the life. We don't have an option. And I would say, and I'm not presented that data, 100% feedback, and more than 100 patients has said that they would like to go on the clinical trials if there is anything and any opportunity. When I was fighting, becoming partner, speaking with the policy makers, with the pharma companies, I don't have an option. You won't believe, I was joining hands and touching legs to people at that time, because that was the case. So I think from the patient perspective, they would open, but yes, it helped when we were discussing, and that's how when in the patient advocacy in our support groups, like the global support group, we are now having the framework, what question should be asked, what should you go with, what preparation you should go with your oncologist. So from our experience, we are helping others.
So I think what Dr. Harit said, I think we need to go beyond the Maxes and the Fortises and the Kokilabhen and the Tata Memorials to actually what organizations like ISSLC must do and should do and can do, because what example you gave was of IASLC. IASLC has a very, very strong patient advocacy program, and they have a completely separate session on this. So that would be a very good start, Vivek, and I think that's something that we need to carry forward from.
Sure.
Thank you. I think this is very relevant. I will not say thank you to Vivek, because I think this is the beginning. This is not actually end of a talk. I think this is the first thing, Vivek, that we are starting. You said losing is an option. I think even stopping is not an option, actually. I think we are going to make a new beginning. We will have to brainstorm on how we take this forward, but I can promise you that we will take this forward somehow. I think this will change, and we will remember this day for years to come. But the day has to end, and so it has been a phenomenal day. We heard science like never before, and it has been a phenomenal end of the day, because we've all been enlightened and learned a little bit more, and you've touched each of our hearts and each of our minds and each of our spirits. So I thank you for that, and I thank you for everybody participating today. But tomorrow, sharp 3:45, we are going to start again. with a very interesting book launch. And then we will follow that up with the whole day's program. And Vivek, do join in tomorrow also. I think you will enjoy that.
Sure, thank you.
Thank you, everyone.
Thank you.
Thank you. Take care.